Dr. Poonam Joshi, welcome you all once again to our TMC Postgraduate Teaching Webinar 2026. This is the next year of our conference, and this webinar basically aims to focus on the basics of operative techniques and discussions in head neck surgery. With this, I first of all welcome Dr. Pankaj Chaturvedi, sir. Sir is Director of ACTREC, Advanced Center for Treatment Research and Education in Cancer, Tata Memorial Center, Director, International Federation of Head and Neck Oncological Societies, and President of Foundation for Head Neck Oncology, India. So, sir, I welcome you for the welcome address.
So good afternoon, good evening, everyone. This is certainly a very important event where we are discussing very important cases that many of you will deal in your day-to-day practice. So our aim is, and that is what Poonam and the team have prepared a very nice program where the cases that you will get for your exam, the cases that you will get for your routine practice, they're all included. So I would encourage that each one of you should not only listen to what is being said, but also put your questions on the chat box so that we are able to answer to those questions. And of course, there will be an opportunity not only during this webinar, but you can leave behind your questions and Poonam will try to get the faculty answer your questions even at the end of the seminar when perhaps you may not have time to continue the discussion or we may not have time to answer to many of the questions. So without further ado, Poonam, we can start with the first case discussion and Tahir can start with his case presentation so that we can have more time for discussion and more time for interaction. So please go ahead.
Thank you so much, sir, for your kind and encouraging words. With this, we move on to our first session of this program. And I hand it over to Dr. Sashwat Mukherjee, who is our fellow in Department of Head Neck Surgery. So Sashwat, please come.
Good evening, everyone. We will now start our first session, a case presentation and discussion on carcinoma of lower alveolus. I would like to introduce our distinguished expert panel for this session. Dr. Pankaj Chaturvedi, sir, is the Director of ACTREC TMC, Director of International Federation of Head and Neck Oncologic Societies, and President of Foundation for Head and Neck Oncology, India. Dr. Kapil Sikka is the Professor of Department of Otorhinolaryngology and Head Neck Surgery, All India Institute of Medical Sciences, New Delhi. Dr. Sajid Babu, HOD and Senior Consultant, Department of Head and Neck Surgical Oncology, Ashton MIMS, Calicut. Dr. Shikhar Sone, Assistant Professor, Department of Head and Neck Surgical Oncology, Amrita Hospital, Faridabad. Our moderator for this session, Dr. Ankur Wali. He is the Assistant Professor of Department of Head and Neck Surgical Oncology, ACTREC TMC, Navi Mumbai. Our presenter for this case is Dr. Tahir Ali Kotwala. He is the third year MCH resident, Department of Surgical Oncology, Tata Memorial Hospital, Mumbai. I would like to invite Dr. Tahir for case presentation.
Good evening, everyone. I'm going to present a case of 52-year-old gentleman. He is a resident of Thane, laborer by occupation, no comorbidities, presented with chief complaint of ulcer over the right lower gum since last 2 months. As per the patient, he noticed an ulcer over the right lower gum 2 months back near the last tooth. It was insidious in onset, around 2 by 2 centimeter to begin with, and has gradually progressed to the present size. It is associated with loosening of the adjacent last lower tooth, associated with pain in the right lower jaw, dull aching, intermittent, non-radiating, aggravated while eating, and it is not relieved by medications.
So
No history
just
of
a minute. So Tahir, when we restrict to only this history and nothing else, okay, so this person had a lesion in the gingivobuccal sulcus, loosening of the teeth, and pain in the right lower jaw, and it is aggravated while relieving. Only looking at the history, what will be your impression?
Sir, my impression would be a ulcer with a differential diagnosis of first differential would be malignant etiology, and the second will be a aphthous ulcer also.
Tahir, we can't hear you. And
Sir, am I
your
audible now?
your camera is switched off, Tahir. Your camera is switched off. The camera in the room.
Sir,
Shashwat,
Yes, sir.
tell
it
the
okay
IT
now?
person to switch on the camera. Camera has been switched off.
Telling, sir. Good night. Good time.
Am I audible now, sir?
Yeah, you're audible. So tell me about. So what do you infer from loosening of the teeth and pain?
Sir, ulcer, loosening of teeth, and pain suggest.
Tahir, somebody else has logged in from the same room with another gadget.
So now is it audible?
Yeah, this is better now.
Yeah. Sir, ulcer with pain and loosening of tooth is suggestive of first differential would be a malignant etiology, and the second will be an aphthous ulcer.
Yeah.
But in aphthous ulcer,
So I just wanted to share with everyone that if you have this history and you are suspecting a malignant etiology, which is a very common problem in India, it's an advanced disease. Loosening of the tooth means that bone is infiltrated, and pain, that means it has gone into the marrow, and also there is a deep invasion, and that is why the patient is having it. So history itself, so I don't know about the patient, but that is what is inferred from the presentation that you have made. Go ahead.
Tahir, can I ask one thing? You
Yes,
have
sir.
you have specifically put the pain is dull, aching, intermittent, and non-radiating. Is that characteristics of malignant pain, or what else did you ask, and what else did you explore in history?
Sir, I've asked about the character first, and I've asked for the pain score according to the visual analog scale, and whether it is radiating to the air or not.
Right.
Because in malignant etiology of the oral cavity, pain is usually referred to the air, sir, depending upon the location of the lesion.
And what is causing this pain?
Sir, either it is because of the ulcer per se, and second, nerve irritation. Third is nerve endings at the occlusal surface of the tooth.
Right. And periosteum and sometimes skin and superadded infection.
Yes, sir.
Go ahead, please.
No history of trauma or dental intervention. No history of bleeding. No history of fever. No history of numbness or altered sensation over the cheek or the skin, or difficulty in talking. No history of change in voice or difficulty in swallowing, and no history of swelling in the neck. There is no history of cough, chest pain, breathlessness, or hemoptysis, and no history of bony pains. There is a past history of road traffic accident 10 years back, for which he underwent nailing of the left tibia. No significant family history. Personal history: bladder and bowel habits are unaltered. He consumed mixed diet. Patient has a history of chewing gutka for 25 years, 5 to 6 packets per day, usually kept in the right lower gingivobuccal sulcus, which was retained for around 2 hours. He doesn't sleep with the quid in the mouth. There is a history of abstinence since last 2 months, and no history of cigarette smoking, and no history of alcohol consumption. So my summary will be: a 52-year-old gentleman, no comorbs, with a gutka chewer since last 25 months, came with ulcer over the right lower gum 2 months back, increasing in size, associated with loosening of the adjacent last lower molar, with no history of cervical lymphadenopathy.
Go ahead.
On general examination, he is vitally stable with a ECOG performance status of 1. No history of pallar, icterus, clubbing, cyanosis, lymphadenopathy, or edema. Systemic examinations are within normal limit. This is the clinical photograph of the patient. With on local examination, there is a swelling in the there is facial asymmetry with swelling in the right side of the cheek below the zygoma. Mouth opening is 2 finger widths with poor dental hygiene and oral submucous fibrosis. So on inspection, there is a facial asymmetry with right cheek swelling visible below the zygomatic arch. Mouth opening is 2 finger width with a grade 1 trismus. Poor dental hygiene with no halitosis with tobacco staining present. There is oral submucous fibrosis, and there is a ulceroproliferative growth in the right buccal mucosa of size 4 by 3 centimeter. It is irregular margin with everted edges, the limits of which is premolar anteriorly, and it is reaching up to the retromolar trigone posteriorly. Right lower alveolus and the lower gingivobuccal sulcus is involved. Floor of mouth and the upper gingivobuccal sulcus is free. Right lower second and third molar is missing, and there is a gross paramandibular disease present. There is also a 2 by 2 centimeter whitish homogeneous leukoplakic patch over the left buccal mucosa. Rest of the buccal mucosal examination is within normal limit. On examination of the neck,
two questions. Go back. No, that next slide.
Okay.
Yeah. So 2 things that I want to ask from you. The history of gross paramandibular disease present. Now, why did you take this? And second, you have written that oral submucous fibrosis present. So, what is the relevance of these 2 situations, and why did you take this history? And third, the 2 by 2 centimeter leukoplakia plaque that you found on the opposite side, what are the relevance of these 3 things? Submucous fibrosis, paramandibular disease, and leukoplakia on the contralateral side.
so first, gross paramandibular disease would change my plan from in the treatment, in the final outcome of the surgical planning will be changed from mandibulectomy versus segmental marginal mandibulectomy or segmental mandibulectomy, depending upon the location. So gross paramandibular disease would warrant segmental mandibulectomy depending upon the location of the disease. There is also leukoplakia in the left buccal mucosa, which is indicating that there is some there is field cancerization, and it is going to convert into the malignancy depending upon the. We will discuss with the patient whether we want to excise it in the first go or no. And oral submucous fibrosis is the potentially malignant disorder which could lead to the disease which is seen now.
Perfect. So just to add to that, you have covered most of it. So the oral submucous fibrosis is a generalized problem. It is not restricted to where lesion is, but even contralateral. So sometimes when you are doing surgery, not in this case, if the trismus is very severe, submucous fibrosis is very severe, then you may have to do contralateral band release as well, so that during the surgery you are able to make adequate mouth opening to give proper oral aperture. And gross paramandibular disease, you are absolutely right. It allows us to distinguish whether we can do a marginal or segmental. And for the leukoplakia on the opposite side, this only tells you that you should examine the oral cavity very well, the floor of mouth, the gingiobuccal sulcus on the opposite side, because these patients up to 10% may have, particularly with such a long history of gutka usage, they may have some precancerous lesion in rest of the oral cavity, in addition to the oral submucous fibrosis, which may need to be addressed during the surgery itself.
Yes, sir.
Tahir,
Yes.
sir, go ahead, sir.
Yes, sir.
You have also noticed some asymmetry of face. What comes to your mind with that, and what is your interpretation?
Sir, it is suggestive that the disease is locally advanced or very advanced, depending upon the further investigation. And it also suggests that it is only suggesting that the disease is very, locally advanced at this stage, and we need to rule out by doing further history and palpation and the radiological investigation.
Right. It tells you that it's either subcutaneous or you need you need a more thorough cutaneous assessment or skin involvement assessment, and maybe subcutaneous lymphatics.
Yes.
Yeah, Dr. Shikhar.
Tahir, you mentioned about you showed a picture of mouth opening being less, about 2 finger breadths. So did you cover that in the history? What is the relevance of this decreased mouth opening?
So it is a 2 finger breadths mouth opening, which is approximately 3 centimeters. So it is a grade 1 trismus. I have mentioned in the mouth opening.
Yeah. What else regarding trismus would you ask in history? Would you cover in history, which has a significance in the which tells you something about the cancer as well?
Sir, whether it is a new finding or whether it was there since in the past also. So if it is a new finding and it is associated with pain, then it is signifying that it is involving the masticator muscles, and it is probably a locally advanced disease.
Yeah, and if it's old, previous, then?
Sir, it is because of the oral submucous fibrosis also, trismus, and
right. So what is more ominous for you? I think you're muted again.
Sorry, sir?
What is more ominous for you? What is more ominous in history? What is, more significant? A recent onset is trismus,
recent
or a
onset is more recent onset would indicate that we are dealing with locally advanced or very advanced disease, depending on the further radiological investigation or clinical palpation, clinical radiological investigation, I would say.
Right. Another question I wanted to ask you is, you mentioned that the patient, regarding the leukoplakia on the opposite side, you mentioned we'll discuss with the patient whether it needs to be excised or not. Is that always the case? Do you always, would you, are there any clinical factors that would push you towards addressing the leukoplakia in the same setting, or you can observe few leukoplakias?
Sir, depending upon the leukoplakia, whether it is homogeneous or heterogeneous, If it is heterogeneous, then the chances of getting converted into the malignancy is more. So we would like to address the heterogeneous leukoplegia in the same setting. If it is a white, in this case, it is a homogeneous. It appears to me as a homogeneous. So I would like to go ahead, but I will first discuss with this with the patient also.
Right. Okay. Go ahead.
So there is a gross paramandibular disease on the right lower buccal mucosa involving the alveolus. And this is the clinical photograph of the whitish homogeneous leukoplakic plaque on the left buccal mucosa. On palpation, the ulcer is 4 by 3 centimeter in size. It is tender and it is irregular margin with everted edges with indurated base. It doesn't bleed on touch. The skin appears to be fixed interiorly. No local rise of temperature. Neck, it is on examination of the neck, there is a 1.5 into 1 centimeter solitary form mobile lymph node in the right level 1B, not fixed to the overlying skin. No other palpable swellings in the ipsilateral or the contralateral neck. Oropharyngeal examination is within normal limit and Hawkins examination is within normal limit. So my summary will be a 52-year-old gentleman with gutka chewer. Came with complaint of non-healing ulcer over the right lower gingivobuccal sulcus of size 4 into 3 centimeter, reaching up to retromolar trigon with skin involvement with solitary mobile level 1B lymph node on the right side. Most likely of the malignant ulcer of the right buccal mucosa with clinical staging of T4A and N1.
Perfect. So, Tahir, you have done the examination, you have done the good history taking also. What is the first? The patient has come to you in the OPD, okay, and he is a new case, and you don't know anything about, what he did in the past, or some investigations were not done. So, what is the first thing you will do in the OPD?
Sir, after clinical examination, history and clinical examination, I would like to go ahead with the since this patient there is no history of bleeding in this patient, so I will like to go ahead with the biopsy front and then advise radiological investigation.
So, do you take any special precaution when you are doing the biopsy? Why I'm asking the question, because I'm sure in this case we will be having a lot of maxillofacial dentists and some young doctors. So, Tahir, can you tell in the OPD when you take a biopsy, do you take any special precaution? Is it something worrisome? Do you have any bleeding? Or you think it's a very routine thing which even first year can do when it comes to?
Sir, while doing biopsy, it is very important to take the biopsy from the most representative aspect of the ulcer and not from the necrotic part. So the yield will be more and we will like to get the result in the first biopsy itself.
And do you encounter bleeding after the biopsy, which has really been troublesome for you?
Sir, it is very unlikely if you take the sample from the edge or from the representative sample, and if it is there, then it is usually controlled with the H2O2 gauge piece.
And have you ever taken the patient to the minor OT for doing punch biopsy for such a lesion?
Sir, if the mouth opening is not adequate, then we need to do the investigation first and then radiological investigation first. And under examination under anesthesia, we would like to go ahead with the biopsy in that particular setting. In this case, since the mouth opening is approximately 2 finger breadths, so we will comfortably take the biopsy from the representative section.
And is there any role of doing some scraping and then sending it for cytology?
Sir, there is no role of cytology per se in buccal mucosa ulcer for the to rule in or rule out malignancy.
Okay. And if you have done a biopsy from the oral cavity, do you still need to do FNAC of the node?
Sir, it is not required.
Perfect. Thank you. Kapil, Shikhar, if you want to ask before he proceeds.
You said node is solitary. and from your description, it seems it's mobile. Does that change the management? It might be mobile, and you have categorically said you will not sample it. What are your points for and against that?
Sir, as per the history and the clinical examination, I'm most likely dealing with the locally advanced buccal mucosa malignancy. So it is not going to change my plan of management whether I'm going ahead with FNSE or no. Since I'm anyway going ahead with the formal level 1 to 4 lymph node dissection, then it is not going to change any treatment plans by doing
If it is a
FNSE.
metastatic node, still your neck dissection will entail 1 to 4.
Sir, if it is level 1B or 2A is positive, 2B is positive, 2A is positive, then I would like to go ahead with 5 also. Since it is a retromolar trigon primary and the chances of level 5 primary in a retromolar trigon primary is high relative to the other malignancy, relative to the other subsets of the oral cavity, then I would like to go ahead with level 5 lymph node dissection in that case as well.
You, in sir's questions response, you said examination under anesthesia. What is your choice of anesthesia and how do you do that?
Sir, in our setting, we do nasal intubation and then examine the oral cavity.
Okay, but not before biopsy. That is for your final operation.
Sorry, sir?
Do you assess all the patients even before biopsy, or is it at the time of operation that you assess under general anesthesia?
Sir, at the time of biopsy as well, and because if the mouth opening is restricted, then we first examine the patient under local anesthesia before planning the final surgery.
So let me paraphrase the question. It's a very important question that Kapil is asking, Tahir. What is the role of examination under anesthesia in an oral cavity cancer patients?
Sir, examination under local anesthesia, can be done when the posterior limit of the lesion can't be assessed. For example, in a tongue primary, if it is reaching up to the hyoid or vallecula, then the posterior limit of the lesion needs to be ascertained first before planning the surgery.
And also sometimes you have very painful lesion in the floor of mouth, which patient may not allow you to examine in the OPD. And therefore, whether to plan for a segmental mandibulectomy or to preserve the mandible, that examination sometimes may require in a very painful tongue lesion or painful lesion, examined under anesthesia.
Yes.
Right. Someone wants to ask a question if moderator allows. It's in the chat.
Tahir, any role of
if you
PET?
can read. Yeah, sir,
Yeah,
please.
Sir, Kapil sir, go ahead, sir. I'll ask later.
No, it's okay. I just requested the moderator to read the chat also. There are few questions and someone wants to ask the questions.
Question is, the question is, Anand Rege sir asks, do you use a graded scale to measure interarch opening in your day-to-day oral oncology exam? And have you conducted the through extraoral exam of this patient neck? If yes, what were your findings? So the Tahir, the question is here, how you measure the interincisal distance in your routine practice? And what is the extraoral examination findings? Like, what is the neck findings and what is this edema and the subcutaneous tissue involvement? That sir wants to know.
Sir, can you repeat? Your voice is not clearly audible to us.
So let me again say, Dr. Rege, what Tahir has already presented, that for interincisal distance, they use the scale. And for graded mouth opening, again, they use the scale. And for the next question was that, did you do extra oral examination? Yes, he presented that the extra oral, that skin and subcutaneous tissue and the paramandibular disease, plus the neck node, all those findings he presented. Shekhar, you want to ask anything?
Yes, sir. So, Tahir, any role of doing a PET scan for this patient?
Sir, there is no added advantage of doing a PET scan in a upfront treatment naive buccal mucosa malignancy.
Even in advanced cases like this, that's a very radical statement to make.
Sir, we would like to go ahead with metastatic workup in this case with a CECT thorax also, with head neck with CECT thorax.
Any scenarios in which you would prefer a PET scan, maybe?
Sir, in a recurrent cases,
No, in an upfront case?
in upfront, if
Or
it is a
always
gross,
you're saying always CT thorax is, I know routinely you would do CT thorax for locally advanced cases, but any particular scenarios in which you would maybe want to add a PET scan?
sir, bilateral level 3 lymph node, bilateral N3 neck nodes with buccal mucosa primary reaching up to the high ITF, then it might be, we could think of, but NCCN doesn't recommend PET CT, and in our institute, we usually doesn't do PET scan in a treatment naive case.
No. So what is the role of PET CT is the question. So the answer is very clear. N3 node, no need to be bilateral. N3 neck nodes, they have high likelihood of that. Second is that nodes reaching up to the root of the neck, they are likely to be worse in prognosis. In oral cavity, I'm talking about. And then, of course, T4B, because you want to know whether it's a metastatic disease or it is a localized disease. So these are the few indication why I'm taking time, because we have less time and we have to cover a lot. So for all the attendees, these are the indications of PET CT in a treatment naive patient who has come to their OPD for the first time with oral cancer. Kapil and Shikhar, you want to add something?
No,
No,
sir.
sir. I wanted this him to say level 4, level 5 nodes probably, because they'll have metastasis, extra thoracic metastasis as well.
Yeah, agree. Go ahead.
This is the contrast enhanced thoracic abdomen, head, neck, and thorax of the patient, same patient. So we usually do puff cheek technique, and in this,
Can
we
you
are
please
seeing.
carefully focus on the pterygoid plates and pterygoid muscles? Just these two regions to be more specific.
Ma'am, this is the lateral, sir. This is the lateral pterygoid and medial pterygoid, and the it is not involved in this case. As we go down, we are seeing a region in the right buccal mucosa in the RMT region. And on bone
The
window,
masseter, how's the masseter?
the masseter is involved in the interior aspect. And on bony window,
So while you're seeing the scans, quickly answering to two questions, that
yes, sir.
if there is a bleeding during the biopsy, what we should do? Don't worry, just put a gauze piece there, pack it, it stops. So there is never such thing that it is such a bleeding that you have to admit the patient. Role of breast biopsy, short answer is there is no role of breast biopsy. Go ahead, Tahir.
Yes, sir.
Kapil, would you like to answer these two questions? When to use Hopkins, and maybe Shikhar can ask about what is the role of neck imaging or evaluation in management?
Hopkins for second primary is more or less routine in all head and neck cancers. We prefer flexible laryngoscopy because that's more physiological rather than Hopkins. And Dr. Shikhar?
Yeah, so the question is neck node with an unknown primary, right? So that is, of course, a whole topic in itself. But the first thing in when we have established that it's a metastatic node, we need to ascertain which level it is, level 2, level 1B, level 3, level 4, because the putative primary site could depend depending on at which level the node is. And usually the first choice of investigation, the radiological investigation, would be a PET scan to look at the site of unknown primary. That, of course, is after once we have thoroughly examined the upper aerodigestive tract with a nasal endoscopy and a Hopkins examination and looked at the larynx and piriforms as well. So we'll start with a PET scan in such a case.
So Dushyant, your point is well taken. In submucous fibrosis, 0-degree telescope, excellent suggestion, and we really help. And that also answers one previous question about submucous fibrosis difficulty in examination. So those are the some things that we do apart from the radiological things that helps us evaluate the extent of the lesion. Kapil, would you like to answer what is the role of concurrent CT-RT versus RT in patients with ENE negative?
Oral cavity with in this scenario, I will feel that it should not be first line curative intent treatment. If you are talking in adjuvant setting, then probably ENIE negative with only skin involvement and extensive stage of disease, as in this particular state, is not the protocol at our center.
Okay. Agree. Okay, go ahead, Tahir.
Yes, sir. Biopsies came out to be moderately differentiated squamous cell carcinoma. And we have done the staging also, it is non-metastatic. So I would like to discuss with the patient the further treatment options in the form of surgery upfront.
Tahir, could you just summarize the radiological findings first before going to treatment?
Sir, it is a right buccal mucosa lesion involving the skin. Buccinator is breached and it is not involving the bone. And neck nodes are not appears to be involved in this case, sir. And it is non-metastatic on lung window.
Shikhar, there is a question, there's a very standard question that whether we should have done MRI or should we do CT scan. If we have already done the CT scan, should we repeat the MRI for bony involvement?
Right. So usually to assess the bone, as in this case, we are more interested in assessing whether the bone is involved or not. So for that, I think CT would suffice. MRI is usually preferred in tongue and flora mouth tumors and pharyngeal tumors, but for this, CT is good. Lower alveolar tumor, seeing deep bony infiltration, deep bone erosion, and we clinically is telling us about involvement like numbness in the cheek and all those areas towards the forehead, and we're suspecting fossa involvement, then maybe an MRI can. Otherwise, CT majority would lower alveolar tumor.
Yeah.
Sir, I will feel is definitely more distinctly seen because of the characteristics of MRI. This patient in background of trismus, suspicious masseter involvement, I will MRI also as the investigation before surgical planning.
Yeah, so it all depends upon the institution, because if you look at the sensitivity, specificity of CT scan and MRI for these lesions, if you look at the numbers are very small. Studies, they have looked at additive value for horizontal infiltration and all that. Here, I would say that more look at the CT scan themselves. If you see the patient and the CT scan yourself, you may not require many of patient, because as Shikhar was saying and Kapil also said, itself is so telltale that or any investigation to so each one of, if you leave it to the radiologist, can prefer MRI because not the patient but the scans which are very very important, and they MRI because they are more confident of reporting whatever Kapil and Shikhar are saying. But when a patient already has a CT, what is the additional value beyond the information that we already have? And what Shikhar rightly said, and Kapil also said, if you are having any suspicion in a small subset of patient, you may repeat it, but or as a routine that anybody who has a in addition to the CT scan, we must do an MRI. Yeah.
Good evening. Good evening, Sajid Babu. With Pankaj sir's opinion, and though we are not going to decide bar marginal, here we will have to see the extent of the segmental significant paramandibular spread. So the CT scan, in the CT scan, the surgeon should have an idea to do the segmental, at what going to do the cutting of the mandible, because we will have to look do it.
Go ahead.
Yes, sir.
Pune is already 5:42. Tahir,
Yes, sir.
it's already have time to go ahead, or should we move to the next case?
Sir, we have another 5 minutes, sir. We can do it for
Okay,
another
go
5
ahead.
minutes.
Yes, sir. I would like to offer the patient upfront surgery with in the form of since the skin is also involved, right buccal mucosa, white excision with segmental mandibulectomy, and ipsilateral level 1 to 4 lymph node dissection, ipsilateral level 1 to 5 lymph node dissection.
Sajid, somebody talks that if
pre-flap.
CT scan is already done USG for the neck. So would you like to handle that question?
Since we have already, I think CT scan is a good sensitive modality for picking up the node. I think additional ultrasound may not help us unless if you and see do an USG guided FNA, because in this patient being an ipsilateral neck, we expect an ipsilateral unless there are large number of nodes in the right side of nodes usually, but still we may have to confirm with USG guided FNAC for option, otherwise not required.
Sajid, there is one more question. Upfront surgery versus peri-op immunotherapy. This is the standard question that we hear these days. Keynote 689.
In the light of Keynote 689, probably this becomes a locally advanced disease. He may be a candidate for immunotherapy with the neoadjuvant immunotherapy, but cost factor is the biggest hurdle in our country. So we will have to discuss with the patient. But we have been treating these patients with surgery followed by adjuvant radiotherapy plus or minus chemotherapy. And many of these patients, when they do not have neck nodes, they still do well. But surely advanced as per criteria, he is a candidate.
Have you incorporated in your practice is my query too, Pankaj sir also?
Yes.
No.
Yes,
So
we do.
as
with
of
us,
now, we have
Yes,
to
sir.
still wait for the maturity of the data. There are a lot of lacunas in Keynote 689 before we incorporate in our treatment paradigm, especially what Sachit said about the cost implication. If there
Yes, sir.
is a significant survival gain that we are giving with our current treatment protocol, I need to be very confident I'm adding such an expensive therapy for an increment of 3 to 4% or 5%.
Correctly said, sir. So we should be more conscious and confident on the surgical clearance in this patient. So a good plan with a good surgery, with getting an adequate margin and a good reconstruction will surely help in this patient.
Yeah, I agree with you, Hitesh. We are only looking at progression-free survival at this point, not the survival.
Yes.
Yeah. Anybody, Shikhar, Jeftin maintenance dose. Shikhar, your mic.
I don't, yes, sir. I don't think this is the question. In locally advanced lesion, since adjuvant RT takes time, can oral Jeftinib maintenance dose be given till start of RT to prevent local failure? I am not aware of any such robust data to support this sort of practice. I think as far as possible, we should stick to 100 days of package treatment package time and initiate RT as soon as possible. I would not be a proponent of Jeftinib, maintenance Jeftinib in the interim period.
Perfect. Poonam, it's 5:45 now.
Sir,
Yes,
we are
sir.
running out of time. Why?
Yes, sir. We can wrap up, sir. Thank you.
Ankur, you can wrap up. I have taken your role as a moderator. I'm sorry.
Yes, not an issue, sir. Sir, I request the panelists to grade Tahir for his presentation.
So my grade is out of 10 or out of 5?
Out of 10, sir. Out of 10.
So for me, it's let Kapil and Shikhar and Sajid go first because I have a conflict of interest.
I would put it as 7.5 out of 10.
Okay,
I think I can give 8 also. There is no issue.
Kapil, sir.
I'll give him 7.5 out of 10.
Shekhar, sir.
Yeah, I would give him 8 out of 10. He answered most of the questions well. Maybe radiology you can read a little better. The rest was good.
Yeah. Thank you, everyone.
Thank you, sir. Thank you very much. Thank you, Tahir.
Thank you, sir. Thank you, sir.
Thank you to our esteemed expert panel and moderator for this session. And now we can move to our second session, that is operative technique discussion, infratemporal fossa clearance. Our esteemed expert panel for this session is Dr. Dushyant Mandalik. He is the Senior Consultant, Department of Head and Neck Surgical Oncology, HCG Cancer Center, Ahmedabad. Dr. Chandrasekhar Dravid, Professor, Department of Head and Neck Surgical Oncology, Tata Memorial Hospital, Mumbai. Dr. Hitesh Singhavi, Consultant, Department of Head and Neck Surgical Oncology, KIMS Hospital, Thane. Dr. Gurukirti B. Kedilaya, he is the Assistant Professor of Department of Head and Neck Surgical Oncology, Kasturba Medical College, Manipal. Our speaker for this session is Dr. Neeraj Trivedi sir. He is the Medical Director and Head of Department of Head and Neck Surgical Oncology, Sankush Medicity, Mehsana. Sir, I am now stopping my screen sharing. Neeraj sir, you can start your screen share.
Thank you very much, everyone, and good evening to all. Really appreciate giving me an opportunity to, so I'm supposed to give you a talk on infratemporal fossa technical aspect. So how I have conceptualized this, we have 4 very eminent panelists. So first I will show the video of how I do a compartment ITF clearance, and then we will have a small panel discussion to receive opinion from other experts. Is my video slide visible?
Yes, sir.
Okay, good. So it's a case of left buccal mucosa and RMT, and we are raising the cheek flap. The flap always needs to be raised beyond buccinator muscle in the subcutaneous fat plane. Once you go posteriorly, raise the flap over masseter fascia so that you can preserve the upper branches of facial nerve. Now, posteriorly, you go to the posterior border of masseter between parotid and spread that. And above, we are going till zygoma to detach masseter muscle from zygoma. Once you detach masseter, you get to the buccal pad of fat. You gradually tease it down. So you start seeing the posterolateral wall of maxilla. Now we are creating a plane between masseter and parotid. There will be small blood vessels which you have to cautery while you come in contact. The concept of compartment is to take the entire components of ITF in a single go. Now we are reaching the posterior border of mandible. Now that's digastric angle of mandible. And what I'm palpating is the styloid process. So what I have released is a stylomandibular ligament. The moment you release a stylomandibular ligament, you enter the parapharynx space, the deep lobe of parotid area. First, you have to assess this to make sure that the tumor is operable. Now we are at the sigmoid notch. That's coronoid process. So from posterolateral wall of maxilla, where my retractor is, to the coronoid process, going backwards, we have to make sure that's the posterolateral wall of maxilla. That's temporalis in the depth. And posteriorly, there will be lateral pterygoid muscle. So this entire component of infratemporal fossa or masticator space needs to be taken out and blocked. So the first step is to do a anterior cut for the mandibulectomy. Once you do that, you release the mylohyoid muscle. Once you do that, you go to the medial aspect of the floor of the mouth area. You make sure that you take adequate margin. Sometimes with trismus, if you can't see properly, you may go close to the tumor. So once you do that, this is the lateral pharyngeal wall. Now this anatomy, I'll pause and explain. This is my finger is just below the medial pterygoid. This entire is the lateral pharyngeal wall. You can see the soft palate here, uvula here. So this is where you can take your posterior margin while tumor is anterior to you. So this way, with this 3-dimensional compartment approach, you can comfortably access the posterior part of the tumor. So we are releasing that's a lateral pharyngeal wall, and my finger is in the parapharynx space. So this is very, very important for all of you to understand that this way we have managed the posterior aspect. When we go to ITF, we'll manage the superior aspect. So this is anatomy of parapharynx. That's a medial pterygoid muscle. That's deep lobe of parotid. And that's lateral pharyngeal wall. And we are above the styloid process. So this is a pre-styloid parapharynx space. Now that's the tumor you can see. It's completely anterior to where we are dissecting, and we are also not struggling because this is coming from posterior to anterior, moving the tumor above. So this way we have full control over the posterior aspect of the soft tissue dissection. Once you do that, you make the subcondylar osteectomy. Either you can remove the condyle, but to do subcondylar osteectomy is technically easy, it's faster. So we do this. Before that, you would have ligated the internal maxillary artery just below the condyle so that the bleeding is much less. You can see the clip being applied there, already there. So now once you do this, you will expose the lateral pterygoid muscle. Now again, a very important point here. At this time, if you can keep your systolic blood pressure around 80, a hypotensive anesthesia, it is significantly going to help you have a very clean field. Now again, look at the direction of the cautery point. It is not going anteriorly, though we are supposed to take the content from anterior aspect. I am pointing posteriorly because that's where I can hit the sphenoid bone very easy. I'll keep on detaching the lateral pterygoid muscle from the condylar head. Use judiciously bipolar and monopolar. Be very patient. And once you do that, you very easily hit the ridge of the sphenoid bone, which is just there. That's where my cautery is. And there's a ridge of the sphenoid bone. The moment I hit that ridge, all I will have to do is stay onto that bone and peel off all the tissue. So you can see the sphenoid bone there. The moment we hit this sphenoid bone, it's going to be easy for us. Now all I have to do is use the cautery, gradually go anteriorly, release first masseter we have released, then temporalis, then part of the lateral pterygoid, but just hug the bone and keep moving anteriorly. You can see very clearly the sphenoid bone there. So this is the landmark that we, once you do that, you can see I'm gradually peeling the tissue off. Again, keeping the blood pressure, systolic blood pressure around 80 really helps. This is where the pterygomaxillary fissure comes when you go anteriorly, junction of the lateral wall of maxilla and the sphenoid bone. And once you go from top to below, at certain point you will see that a pterygoid plate starts arising, and that's where the bleeding starts. So you see I have applied the bone wax. I'll show you in detail little later on. That's the only way to control the bleeding in foramina, but we'll see it later. Now you can see the infiltrative tumor in the RMT and upper alveolus. Always take generous mucosal margins, 1.5 centimeter at least, because these are advanced tumors and will give you only one chance. Again, you can see I am going to take the soft palate full thickness. So my posterior margin is going to be fine. For preserving uvula, don't cut short on the margins. Take adequate margins, that gives you confidence. So now you can see that's a soft palate and oropharynx area, very clear margins in a multidimensional anatomy. That's it. So this is an area where I want to show this is foramen ovale there and it is bleeding. Now I will show that I'm using cautery to control it. It will not stop. But the moment I put bipolar, so I'm using a bipolar to control it, but it will still keep on coming. But the moment you can see that it has started. But the moment I will put a bone wax, the bleeding will stop. Now to put a bone wax properly, you need a surrounding bone where the bone wax will stick. So that's why you need to clear the upper part of the ITF, expose the sphenoid bone. Now once you do that, you gradually peel off the tissue. That's where the fissure is and the upper part of the pterygoid plate. So you detach the muscles based on the infiltration and then plan your posterolateral wall maxillectomy along with root of the pterygoid. So now you can see that's pterygoid plate there. That's the foramen ovale posterior to the pterygoid plate, and that's pterygomaxillary fissure. So we have a complete we have a complete control of where we want to make our bone cuts. Now make the palatal cut, then anterolateral wall of maxilla, and then go posteriorly to the posterolateral wall of maxilla. Remember that from anterior to posterior, you only reach till fissure. The moment you reach fissure, you reverse the saw, put it in foramen ovale, just below the apex of the pterygoid plate, and direction from posterior to anterior through the root of the pterygoid plate, connecting through fissure to your anterior cut. This way, it will preserve accidental damage of the carotid vessels. Now you release the flimsy fibers that are there, so you'll get an en bloc margin. So that's the final anatomy. The forceps that I'm holding, you can see the eustachian tube there. So that's a lateral wall of the nasopharynx. My suction right now is in the pterygomaxillary fissure area. And this area which you are seeing, so that's pterygomaxillary fissure, that's fissure area. That is eustachian tube, you can see. So you can take up to anterior wall of the eustachian tube. Carotid lies deep to the posterior wall. And this is your foramina ovale and sphenoid bone. Now we can see the margins all around. Mucosal margins are good. And then this posteriorly, we don't even have to look at the margin because we have a nice smooth cover of the normal masticator muscles around the tumor. So we feel very confident about a good negative margin all around the tumor. So this was a video. Now I would like experts to make a comment, or should I start with the panel discussion and that where I take the comment?
Hello.
Yes.
Yeah, Dushyant here, Nirav.
Yeah.
Excellent demonstration of ITF. And I have had privilege to see you operating live also, and in the cadaver dissection also. I just 2 or 3 points which I think I can add here. Maybe due to time limit, you have not addressed that. That is the ophthalmic branch of the facial. Early on, you identify while you are actually peeling off your parotid off your masseter. So that will save your eye sphincter and later on problems due to that. I think that is one thing which I will like to add. I usually try to do the soft tissue releases first. So when you do the bone cuts, the entire specimen comes in toto, and do the IMA ligation early on, which helps to have a bloodless kind of a field. So I think these are 2, 3 points which I will like to add, but excellent demonstration.
Thank you. So yes, I agree that preserving eye branch of the facial nerve is important. And how you do it, which I showed briefly, is you stay on the masseter and lift the masseter fascia. Automatically, that branch gets saved. But again, I will tell you, we see a lot of buccal cancer with skin infiltration. And in those cases, do not worry about any of the nerves. Make sure that you go wide enough, adequate enough to get soft tissue margins negative. These patients only give you one chance. If you fail now, this patient is a dead patient. So again, where you can, definitely, as Dushyant said, you should. And otherwise, if it's needed to be resected, be bold enough to resect. Second point, again, yes, you always ligate the internal maxillary first. I didn't show in the video, but there was a clip there. Also important for everyone to understand, sometimes if you are struggling to identify intermaxillary behind the sigmoid notch, you can track the external carotid artery just in the deep lobe of parotid where it comes from the digastric and stylohyoid, and ligate the external carotid itself. It's much more easier and you will feel much more confident. The only side drawback is sometimes if you want to use a forehead flap for salvage, then you may struggle. But again, wide-based forehead we regularly do in this type of patients if the flap fails or sometimes needed, and it still survives. So that's another tip that I can give. Now, should I move on to panel? I have some slides prepared so that all of you can give your input. Is it okay?
Yes, sir. Please go ahead, sir.
Okay. So let's go from basic. I want to ask the panelists, Hitesh, Dushyant, everyone, Chandrasekhar, when as a surgeon, you have 2 or 3 options to select an approach, what are the points you will consider while selecting a good approach that gives you decent oncological outcome? Any one of you? Just broad question as a surgical oncologist.
As in approach, Nirav, you are.
So say there is a option to go. So in this case, compartment versus conventional or anything, just a transoral versus lip split. In general, what
So
are
I
the
think,
points you would consider?
yeah, I think Nirav, one thing is very clear, and I think it should be very clear to the trainees, is that any approach you take, first thing is that your oncological clearance. Uh, if you are taking some non-invasive approaches or the approaches which avoids incisions, but you are not able to actually do an R0 resection, I think that is not right. So R0 resection is must, whatever approaches you take. Then comes your training. What is your training, right? You can build slowly on your training to do less and less invasive approaches like intraoral or without lip split or raising bucket handle flaps. But that comes with the training, and your benchmark still remains your good R0 clearance. So I think these two things are cornerstone to any of the approach you take.
Thank you, Dushan. Hitesh, you
So,
want to comment?
sir, excellent. Yeah, sir, excellent tips from Dushan sir and excellent video demonstration from Nirav sir. Great to learn from you all. The other point which I wanted to add is especially in ITF clearances, the average blood loss documented is between 1 to 1.2 liters. And as you as already mentioned that keeping the patient in hypotensive will definitely help you. So especially in such scenarios, your basic aim is to get first RO resection and for ease of surgery, as is already mentioned, for keep yourself at ease because you're expecting storm ahead, especially while doing ITF clearance. Because if you don't plan it and then you encounter bleeding, the approach, even if you extend it, it will be much bloodier.
Thank you. So to summarize, you want to have, Dushan said, you want to have good oncological clearance all around. Hitesh said ease of surgery, proper planning is important. I will add few points. You want to have an approach that gives you consistency of results and reproducibility, because you don't want like very good outcome in 3 patients and then other 2 patients suffer. Also minimize the cosmesis and all. So I'll just summarize what are the challenges when you take on deep infiltrative tumors that are located posteriorly in patients with submucous fibrosis. So we all know that the conventionally we are taught from going from anterior to posterior. So cut the mucosa, go through the soft tissue, and then you feel you are deep enough, you round it off from the posteriorly. But some of the posteriorly located tumors who involve multi-dimensional, like RMT area will also involve lateral pharyngeal walls, oropharynx area, go to the nasopharynx, laterally get into the ITF tissue. So in this, if you only approach from anterior to posterior, you will struggle. So that's where you need to really combine the neck and the parapharynx space approach with the intraoral approach and come from both the directions so that you get a negative margin. Now, when you address buccal mucosa, there are 2 questions that comes in my mind. One is, when do we have to clear infratemporal fossa? Not every patient, every buccal mucosa, every RMT actually needs ITF clearance. So that's one question that we should address. And second is, which approach to use for masticator space? So there has been a conventional approach proposed by Liao et al. And then we proposed a compartment, a standardized clearance for every single ITF. So we briefly summarized that Liao et al. Divided the tumor into low infranotch and high ITF, and our work has further subdivided level, low infranotch into grade 1A and grade B, and high infranotch again into intermediate grade, which is grade 2, and grade 3, which is very high. So because we are running short of time, I'll just summarize how I decide to select case where I will need a complete compartment ITF or a standard resection with a masseter and medial pterygoid. So we all agree that tumor that has gone grossly into infratemporal fossa involving say lateral pterygoid, tuberosity area, part of temporalis, we have to do a complete compartment ITF because tumor is sitting there. But then if we look at the anatomy of the ITF, we will see that some tumors like 1B who are located at tuberosity area and probably haven't gone into infratemporal fossa. But if I really want to take a 1.5 centimeter soft tissue curve around, I'll have to take the medial pterygoid along with mandible and part of the temporalis and part of the lateral pterygoid, because my bony cut has to come from the root of the pterygoid plate. So to have a clear 3-dimension margin at the depth, I will have to clear infratemporal fossa, even though scans do not show any infratemporal fossa involvement. But because of the location of the tumor, it is important that we clear. So now this is a grade which we all know, probably falsely labeled as T4B, where tumor is a posteriorly located lower GB sulcus tumor involving the lower half of the masseter and probably going to the lower half of the medial pterygoid. This is a case where we need not do a formal ITF clearance. Just a subcondylar tracheostomy removing masseter and medial pterygoid muscles in toto should be fine. But this is a case, even though this would be labeled or histopatho will come as a T1 or T2, where it's exactly on RMT or it's involving posterior upper alveolus in the tuberosity area. This is just because of the location, though ITF tissues are not involved, to get a decent soft tissue margins at the depth, and most importantly, make a bone cut about a centimeter away from where tumor is located. You will have to clear infratemporal fossa for excess. And these are the tumors that, if you look at any literature, any publications, are the ones who significantly fail in infratemporal fossa. So this is something which I regularly practice. Then we all know that the tumor, so Leah et al. Suggested not to operate a high infratemporal fossa, but our work has suggested that the select group of high infratemporal fossa where tumor has not got into fissure or foramina ovale or sphenoid bone or intracranial, you can give them a chance with a proper high ITF clearance, compartment clearance, and these patients have a survival rate upwards between 40 to 50%. So that's a reasonable survival for a stage 4 tumor. And grade 3 where tumor goes beyond into intracranial is not. Now, anyone wants to make a comment on what approach to take? I think all faculties can weigh in and say which one would you prefer, a conventional just a vital excision type of ITF clearance or a compartment ITF clearance, and why?
Hi, sir. Myself, Dr. Gurukirti, sir. Very, very well demonstrated video. As you said, in our practice as well, what we follow is whenever there is a significant involvement of masticator space in particular, so we always go ahead and do upfront compartment resection, because most of the times, even though we feel that we have taken a good margin, and it is very difficult to address this issue by doing a frozen section, unlike where in mucosal margins have been the involvement have been identified through frozen section, and soft tissue is not like that. So we have a difficulty to know whether it's involved or not involved. Only during the final histopath we get the results saying that it's involved. So I think we have changed our practice to compartmental resection whenever there is a significant involvement of either lower ITF or high ITF involvement. So one more question I had. So as you said, in the posterior placed lesions involving the junction of soft palate and hard palate. So what would be your approach? Because through Weber Ferguson, most of us have struggled to get the specimen out, especially during the mostly the posterior part of the specimen. It's always a struggle to remove it. So is there any particular way you practice to solve this problem?
Yeah. So can you see the slide? Okay. Yes. So very important question. Now we have to look at the anatomical diagram. Okay. We have to understand that if the palate lesion stays medial to the upper alveolar arch and has not crossed the RMT to go to the lateral aspect of the tuberosity area, then you can approach safely with the Weber Ferguson and anterior approach. But the moment tumor medial to the arch in the palate area crosses the arch and comes onto the lateral spine and in the area of RMT. These patients with addition of submucous fibrosis make your intraoral cut difficult. Then that's the time where you decide that this tumor needs to be go out through transmandibular approach, not the standard Weber perfusion. Now, Dr. Ram Mohan Tiwari sir, Dr. Moni and my colleague Shilpa have published papers on mandibulotomy, swing the mandible out, take the medial pterygoid, lateral pterygoid, and then do a ITF and then again plate back the mandible. But in a patients with submucous fibrosis and trismus, if the mouth acne is not adequate, this concept will give you lot of trismus post-op. So in those cases where palate tumor going laterally into the RMT area or posteriorly, where I don't feel comfortable with anterior approach, I again do a transmandibular approach, leave the cheek flap. I need not sacrifice the masseter. I can take it with the flap, but then do the coronectomy and small segment, just the size of the coronoid vertical. If you remove, you convert a mandibulotomy into a small segment mandibulotomy, then do exactly same as what we saw in the video. And this also actually allows you to put a PMMC flap. Lot of us work in a remote rural area and not always have access to free flap all the time. So if you do a small segment mandibulotomy, it prevents further trismus as well as allows you to put a PMMC flap, which I think is very, very important. But I hope I answered the question.
So another point of discussion for 1B tumors, which I mentioned,
Yes.
which is involving maxillary tuberosity and not involving the mandible, you would take the coronoid for compartment, but would you take the condyle as well for the compartment resection? Because that will entail removal of another anatomical segment of the body.
So see, the concept for the limited 1B tumor, which is just in the tuberosity area, probably not gone into the... Yeah, so what you really want to do is make a bone cut at the top, at the root of the pterygoid plate and the posterolateral wall higher. Now you come from the anterior approach, you will never be able to go laterally because the temporalis, lateral pterygoid muscle all sit on top of it. So the only option is to come posteriorly. Now there are two ways to do that. One is a small segment resection, like I told you. You can preserve a condyle and you just remove the coronoid area vertical segment through and through. So yeah, you can do that, or you can, if you are experienced enough, you don't have to do a complete segmental mandibulectomy. Do a coronarectomy, and with coronarectomy, you detach your lateral pterygoid, temporalis, and with coronarectomy, you can go through the medial pterygoid muscle, and you can still go to the posterolateral wall of maxilla, like I showed. But that's technically very challenging, and unless you are very, very familiar with the entire anatomy, have done multiple cases, don't do that. Just do a segment mandibular.
So last question from my side. Use bipolar cautery, and you also use
Harmon.
Yeah.
So Hitesh, I don't have harmonic at my place, and I've never used it. Personally speaking, of all the points that we discussed, I personally believe that hypotensive anesthesia is the most important of all. If you can manage your blood pressure around 80, practically you will be feeling like you are cutting like a normal tongue tumor where you are already ligated the lingual vessel. So work with your anesthetist in a tandem, and also don't try to go shortcut. Follow the boundary rules, hit the bone,
step by step.
And that's called compartment. Otherwise, you are doing conventional surgery, and that's the biggest challenge with the conventional surgery. You go through the content of pterygoid. The moment it starts bleeding, neither your bipolar will work nor your monopolar will work, and then you have lost track of where you are, where the tumor is. It becomes a mess.
I think we are running short of time, 6:20. Poonam madam, do we have some more time, or should we wrap up?
I think, Hitesh, we can wrap up because a bit late.
Perfect. Closing comments, Nirav sir.
No, I thank you, Poonam, and everyone, and thank you, panelists, for contributing, and really enjoyed my time. Thank you very much.
Thank you, Dr. Poonam. Thank you, Nirav, and excellent discussion. I think it's good that the youngsters are exposed to this ITF clearance concept right from the beginning, because more you learn from the beginning, you will be a kind of expert in that. This will definitely take some learning curve. Be with your seniors and do it to begin with. I think Nirav and some more centers run ITF clearance course also. You can join that course, 1 or 2 courses, and then you can be confident to do it single-handedly. Thank you, Poonam. Thank you all.
Thank you all. Thank you, Team Attract. Thank you, Poonam madam. Thank you very much.
I sincerely thank our expert panel for sharing such valuable operative insights. I also appreciate Dr. Neeraj Trivedi sir for enriching the discussion with his own expertise. Now we are moving to our next session, that is operative technique discussion, total glossectomy.
Thank you, Poonam. Can you see my slides? Ma'am, we would like to invite the expert panelists for the same ones. Okay. Can I do that, or you can invite? Yeah, please go ahead. We can do that. If you could unshare the screen, we would like to. Okay, I'll stop sharing then. Yes, thank you so much. Yeah.
Now I am pleased to introduce the expert panel who will be guiding us through this session. Dr. Arvind Krishnamurthy. He is the Deputy Medical Director and Head, Department of Surgical Oncology, Cancer Institute, Chennai. Dr. Sagar Vaishyampyan, Consultant, Department of Oral and Maxillofacial Surgery, MGM Hospital, Vasi. Dr. Ashim Mishra, he is the Professor and Head, Department of Head and Neck Surgical Oncology, Mahamana Pandit Madan Mohan Malviya Cancer Center, TMC, Varanasi. Dr. Arjun Singh is the Associate Professor, Department of Head and Neck Surgical Oncology, ACTRIC, TMC, Navi Mumbai. Our speaker for this session, Dr. Anuja Deshmukh ma'am. She is Professor, Department of Head and Neck Surgical Oncology, Tata Memorial Hospital, Mumbai. Ma'am, please start sharing your screen.
Yeah, thank you, Poonam, and thank you, Ankur. I would like to share my presentation. Is it visible? Yes, ma'am, it is visible. Yeah. So, thank you, and I welcome my expert panel. What I'm going to do is like I have split my video into different steps, and I have got some evidence also, a few slides along with it. So I'm going to stop and ask one expert as a short comment every time so that we can wind off and do the justice to the topic in 30 minutes. We have little less time, but I hope we will cover up everything about the oral cavity and mainly the total glossectomy concept for the patient and with the operative techniques. So I'll start my slides. It's not going ahead. Yeah. So any oral cavity, if you're talking about what PG needs to know is the Globocan data. That is 2022 is the latest data. So you need to know that the India has got the highest number of oral cavity cases, and even for the death, if you see the total cases are very, very high. And in main, it is the #1 type of a cancer which we face in India. So that is very important whenever you present your case in an oral cavity. The next thing is the differences between the tongue cancer and the buccal mucosa cancer. So if you look at the buccal mucosa cancer versus the tongue cancer, what you have is the difficulty to take a deep margin in tongue cancer is the most important thing. And the reconstruction is very, very important in tongue cancer because it affects the speech and swallowing. And the 5-year survival is very different, and you have a nodal spread, which is mainly seen in the tongue cancer. So coming to the workup, so this is the voiceover workup slide. I'm just going to play for that.
Workup involves clinical examination if required under anesthesia. MRI for extent, distant metastatic workup by CT thorax or PET scan.
So,
Workup in
so coming to the imaging of the tongue patients, so we do, this is a good article which we have written with the Dr. Suprita Arya, and which gives actually the imaging, which is very important to do a workup for the patient. And MRI is the major tool which is used for the patients to assess how to do the surgery. And one of the most important thing is the classification of the glossectomy, which is used. And what we have going to present is today is the type 5 of a glossectomy. So I can ask Arvind, is there anything you want to add for the workup or a tongue cancer imaging, anything before I proceed with the video?
Yeah, I think it's important to do an examination or anesthesia also, especially in such locally advanced tongue cancers, apart from the imaging, of course, which will give you a rough roadmap of what to expect and with regards to operability. EU examination anesthesia is pretty much very important, and that will sort of make the decision to go or no go essentially. Of course, as you rightly said, history, clinical examination, MRI specifically, and of course, since you're doing a major glossectomy, it's also wise to get a metastatic workup to rule out distant metastasis as well.
Yeah. Any comment from Asim? Asim? Anything to add to this, what Arvind had just said? I think
Asim is not there, I think, ma'am.
Okay. Arjun, is there any comment from your side?
Ma'am, just to add, clinical findings also sometimes, they go overlooked, especially deviation of tongue. These tumors can have hypoglossal involvement very commonly through the perineural spread, as well as any nodal mass, which often may be conglomerate with the primary as well. So just to look out for some, speed changes or deviation of tongue or even pharyngeal palsies.
Yeah, absolutely.
Yeah, and maybe involvement of the mandible also. No, at times you will have to see. That should also be a very crucial. No, whether you really need to do a marginal or obvious. Some cases, of course, obvious frank mandibular erosion is something that you would sort of make out. But then in cases which when it is reaching up very up close, abutting, then in some cases you will have to, and of course EUA will sort of give you the right answer in those
So
situations.
to summarize, basically what you require is the clinico-radiological examination of this patient, and you need to rule out distant mets. You have to rule out inoperability for this patient because of any reason, and you need to plan the extent of the disease, that is the soft tissue and the bony involvement, and the extent of the neck. So let's proceed with the video. Next one.
Case is an advanced tongue cancer which is crossing midline, and we will be doing a major glossectomy, neck dissection bilaterally, and reconstruction for this patient. The operability is assessed and the distant metastatic workup is done. Examination under anesthesia is a very crucial step where the tumor is extent is palpated medially, the laterally, and the posteriorly. Mainly, it is confirmed that the hyoid is free and we can go ahead with the surgery. The dotted red line shows the planned resection, which is type 5, that is total glossectomy in this case, and we plan to do a pull-through approach without any mandibular resection, with bilateral neck dissection and free flap. We have used suprahyoid incision along with the horizontal skin crease incision in this case. In a long neck, we may use a vertical drop or a McPhee incision in a rare situation. The ipsilateral neck dissection is done mainly in and to have the access to the hypoglossal triangle area, and this confirms the operability beforehand. The facial artery is dissected out for anastomosis on the ipsilateral side. The contralateral neck dissection is also done because the tumor is crossing midline. The submandibular gland is kept A-block with the specimen. The concept of compartmental tongue surgery is based on anatomical approach for excision of a tongue along with its potential pathway. Instead of circumferential resection, it is a longitudinal resection which has been done from hypoglossal triangle in the neck towards the oral cavity. It includes excision of the muscles, lymphatics, nerves, vessels, and glands. Abla.
So I just wanted to ask Sagar. Sagar, are you there? Sagar?
Yes, madam, I'm there.
Yeah, so let's have a comment on the incision, because this incision nowadays we take one single horizontal incision. We don't avoid the hyoid. We just take a horizontal incision and we don't try to give any kind of a vertical incision or a McPhee incision. Any comments on the incision? If you have to remove the mandible or marginal mandibular, do you do a different incision or how you go about?
Madam, usually it is the horizontal neck crease incision that usually suffices, unless you have a gross node where the skin also needs to be removed. Otherwise, even mandibulectomy, even marginal mandibulectomy is possible with horizontal skin crease incision.
Great point. Arvind, I just wanted to ask the submandibular gland involvement. How do you remove the submandibular gland? Do you remove it separately with the neck nodes or do you keep it with the specimen, ipsilateral and contralateral? What is your practice?
I think if you are planning a total glossectomy, then it is better to sort of keep it with the specimen, and only then you will sort of be able to do a proper compartmental dissection. Essentially, that's what maybe in the case that you are planning, it will be worthwhile to sort of keep the submandibular gland with the specimen.
Yeah. So this
So
is
involvement per se may be lesser, but then I
Yeah.
think it is the larger concept of having a compartmental clearance. In that aspect, you will have to sort of do this exercise.
Yeah, so I agree totally with Arvind that there are lots of people look at the submandibular gland involvement in a oral cavity cancer, whether there is a occult metastasis rate is how much it is in tongue cancer and all that. It is less, but whenever it comes to a locally advanced tongue cancer, the submandibular gland, the deep portion of the gland actually forms the boundary of your deep margin, and that's why you may have to take it as a compartment as a submandibular gland along with it. What is your
Case is
strategy?
advanced tongue cancer, which is crossing midline.
So, what is your strategy to do the contralateral neck dissection? Asim, can you just tell me what is your strategy to do the contralateral neck dissection in a tongue cancer?
Ma'am, I think Asim is having some problem in joining. He is not there,
No
ma'am.
problem. Sorry. Arjun, I want to ask, sorry, what is your concept about contralateral neck node metastasis?
I think, ma'am, if it is crossing the midline and it's a large tumor, I will definitely address the contralateral node, neck levels. And if ipsilateral is positive, or if the contralateral is also positive, along with 1A, especially, I will again go ahead and at least do a 1 to 4 if it is N0 and a 1 to 5 if it's N plus.
Yeah. Sagar, any comments on contralateral neck node metastasis chances? Do you preserve 5 on that side? How do you go about it? Do you do level 5
Madam,
also?
if neck is positive on clinical examination, clinico-radiologically, I would definitely do level 5. So comprehensive level 1 to level 5 clearance. And regarding the opposite neck, as Dr. Arjun has already pointed out a couple of indications, another indication I would think about is tumors on the tip of the tongue, where I would definitely address the opposite side neck. Yeah.
So correct. So if you have a large burden of a tumor on the ipsilateral side, the contralateral nodal metastasis is very high, and the bilateral crossing midline lesions, the tip tongue lesions, you will do the contralateral neck. And you will, of course, take care of the imaging and look for any nodes, and accordingly you will do it. So let's go to the next concept, is the compartmental surgery has been used
everywhere and people are talking about. Arvind, what is your thought about this compartmental surgery, the Calapranz's article which came in 2009? What do you feel about this compartmental surgery?
I think, of course, many people have not been able to emulate. Very few people have been able to emulate, but by and large, I believe in this concept quite a lot, because it's a block. You take everything, the the muscles, the lymphatics, the nerves, the vessels, and all those things, and also sometimes you have the nodal metastasis also. Sublingual glandal nodal metastasis are also there. So everything has to be taken en bloc. Of course, the results are there. You have negative margins, almost guaranteed negative margins. Then the loco-regional control is excellent, and they have also showed overall survival also is quite good. 2 3 other papers have also said so. As a concept, I think I believe in the concept, and for such cancers, I think it has to be done.
Yeah. Thank you, Arvind, for that comment. Arjun, what is your concept about the TN track, and do you feel this TN track is very important, or it just like one new findings what the pathologist has got?
It does exist, ma'am, because if there is a nodal mass in the neck, it has to come through a tract, which is most commonly through the neurovascular bundle, which does traverse through the part that would ideally encompass the compartment. But in addition to the TN tract, also lingual nodes are important. There is a couple of papers that also discuss nodes which are present in between the musculature of the tongue as well. So if you're doing a compartment, in case you want to address a compartment would address that as well. Additionally, I think the value of a compartment resection is on T3 plus tumors, because if it's T1 and T2, N0 probably is the gray zone. T2 N0 rather, actually. If it's positive neck, you will do a compartment more often than not if it's a large tumor.
Yeah,
And
so
if it's
absolutely. So if you have an advanced tumor, then maybe the compartmental surgery, because you're going to have a more chances of a TN tract or a lingual, a kind of a isolated tumor away from the away from the main tumor, chances are more. So to clear off that, maybe a compartment is the answer in a more advanced tumor than the T2 kind of a tumor. However,
yes.
I just wanted to point out that this is the Amrita Center and another from the Italy, other groups also. They have done the propensity score matching with the wide excision tongue versus the compartmental, and they thought it was a more kind of a comparable or oncological safe. But yes, if you have a higher risk factors, and please go for the compartmental surgery.
Ma'am, Dr. Asim has also joined. He could log in now.
Yeah. Thank you so much for that, Poonam. So just wanted to tell you there are many other concept like kind of anatomical unit resections has been also proposed in 2023, and these are the called as a maths concept, and there are many other concept also. But the moral of the story is you had to have a wide margin, take care of the lymph nodes, take care of the deep dimensions of the tumor, and have a negative R0 resection and do a good nodal dissection. So, Asim, any comments from your side if you are there about the planning or anything, because we just missed you for the initial discussion. In short.
Ma'am, I think I will join in from now onwards, because maybe all those things might have been discussed regarding the workup and everything.
Yes. Okay. So I'll go to the next main video, and after the main video, we will discuss the reconstruction part. Yeah. Thank you. It will be a voiceover video. Let's go for that.
Here is the ipsilateral posterior belly of digastric, which is cut in the neck. The stylohyoid muscle is also cut. The hypoglossal nerve is identified and cut in the neck. The linguofacial vein is ligated. The lingual artery is identified at the greater corner of the hyoid at its origin and ligated. The hyoglossal muscles and the styloglossal muscles are cut. The suprahyoid cut is started. The muscles are cut at the inferior border of the mandible, the anterior belly of digastric. The geniohyoid muscle and the mylohyoid muscles are basically a radiological floor of mouth. So these muscles are cut close to the mandible. The mylohyoid muscle is identified at the mylohyoid line. The inferior genial tubercle are the origin of the geniohyoid muscle. The mylohyoid line is laterally placed. The care should be taken at this point. If you are not hugging the mandible, then you may open up the floor of mouth, which may give a compromised margin laterally for the tongue resection. Slow coagulation is used and carefully the mylohyoid muscle is detached. Here we can see the muscles detach from the mandible and partially done from the hyoid. The contralateral side hypoglossal nerve is identified and ligated. The hyoglossal muscle is cut and the lingual artery is ligated just above the hyoid. The hyoglossal muscle is further cut at the hyoid level and medially. If the extension of the tumor is more, then the lingual artery may be ligated a little lower down. The intraoral cuts are taken 3 to 4 mm away from the gingival margin, preferably at the mucogingival junction, which is shown by a dotted line. This avoids exposure of the bone on the lingual aspect and dental problem. The mucosal cuts are made in horseshoe fashion along the lingual aspect of the mandible from the ipsilateral molars to the contralateral molars. The cut is extended to the retromolar trigon area on the ipsilateral side to get a margin over the tumor. Once the mucosal cuts are done, the tongue is pulled through into the neck. The lingual nerve is cut on the ipsilateral side. The posterior cut is now placed. Ipsilateral tonsil is dissected off from the superior constrictor. The digital assessment is crucial at this point to guide the posterior cut at the vallecula. The cut is extended inferiorly till the level of the hyoid. The contralateral side, the mucosal cuts are taken and deepened. The lingual nerve on a contralateral side is cut. The posterior cuts are not taken intraorally due to poor visibility and access issues. Finally, these cuts are taken at the hyoid bone level, which corresponds to the mucosal cuts at the vallecula. And the specimen is cut slowly till the level of the hyoid. This specimen shows the paradigm shift from the circumferential to the longitudinal tumor resection. It eliminates the potential locoregional metastatic spread. If the mandible is closed, then the marginal or segmental mandibulectomy is performed. Finally, specimen is oriented and sent for frozen for adequacy of the resection. Laryngeal suspension is a critical step after the total glossectomy. Non-absorbable sutures are taken around the hyoid body on both the sides and hitched to the mandible. This pulls the larynx anteriorly and superiorly, and this avoids the aspiration. This lateral border tongue lesion is involving the floor of mouth and crossing midline. It mandates a total glossectomy with marginal mandibulectomy. A lip split incision is made and the lower cheek flap is raised on the side of the marginal mandibulectomy. The inferior soft tissue are cut after confirming absence of disease extension. The dissection is done up to the mylohyoid line in such a way that this will come out along with the marginal mandibulectomy. A boat-shaped marking is done on the mandible and the marginal mandibulectomy is performed with the help of bone-cutting instrument. The contralateral intraoral cuts are made to help the delivery of tongue in the neck. The specimen is pushed into the neck along with the marginal mandibulectomy. The contralateral cuts are taken at tonsillolingual sulcus. The contralateral hypoglossal nerve is identified, tagged, and cut. The lingual artery is ligated and cut. As mentioned earlier, the tonsillar cut is taken, which helps to get adequate margin posterolaterally. The posterior cut is made at the level of vallecula, which corresponds to the hyoid bone. This specimen shows the paradigm shift from circumferential to longitudinal tumor resection. This allows the elimination of potential locoregional site of micrometastatic spread.
This is the another case where intraoral marginal has been done and the same resection as a hemiglossectomy was done. So it's the similar kind and the similar kind of approach has been used for this patient.
Here,
So just to tell about the reconstruction part, I just wanted to ask the reconstruction options basically based on the soft tissue defect and bony defect and something called as a sensory restoration if you can do it. That is the way the reconstruction goal should be, and there are different concept about
the
it.
choice of reconstruction depends on many factors. The most important factor is the percentage of tongue volume loss. For loss less than 1/3, a primary closure can be performed. For loss more than 1/3, with a breach in the floor of mouth will require a pedicle or free flap. In laryngeal suspension, the larynx is pulled anteriorly and superiorly with a non-absorbable suture between the hyoid and the mandibular symphysis to prevent aspiration.
So just wanted to ask Arvind, what is your choice of reconstruction for a total glossectomy patients?
Generally, we would require a bulky flap.
Yeah.
So either a very large anterolateral thigh or that would definitely be the choice, because you will have to have, and the choice would be, you'll have to sort of overcorrect it maybe by 20 to 30%, because generally these patients, the flap shrinks with time post radiation also. So there has to be a sort of a convexity to you should avoid a sump defect basically. So to avoid that, you have to need a bulky flap. So more often than not, I think anterolateral surface for this case. The other point I just wanted to make is, in some of these defects, in the posterior, possible a little bit of the base of tongue. In this case, of course, if it's a total, but sometimes will be fine in the to preserve a little bit of the base of tongue. I think that will help in terms of long-term function.
Thank you, Arvind, for any comments on the video you want to make. Just comments.
Just as Arvind, I would try to preserve of the of the uninvolved side, tumor-free margin. So because that remnant after reconstruction helps a lot in, and also on rather than base tongue mucosa, and all the disease is just crossing midline rather than taking off all the floor of the mouth muscles, little stylohide and the digastric muscle, that the sling and the dynamic intact. So that helps of the patients later on.
Thank you, Asim. Arjun, Pensate flap, any experience with a gastro-omental free flap or any options you have tried?
So, ma'am, in doing large only you are just creating a oral cavity and the neck. In terms of function, if you leave the base tongue, then it makes some sort of advantage. Yeah, so in smaller tumors, we have done one case with omental flap. Again, it just forms a line. We are still an oro. If there is a leak, then quite difficult to manage. And then not, it's more for a plug than for any functional, advantage.
Yeah, thank you. So if you have a tongue resection, maybe you have to pay attention. Tongue tip resection, you can do some kind of adjustment with your designing of a flap is very, very important, so that you have some kind of a mobility and some help for the thing. This is just a last part of the steps of the surgery with the voiceover.
Tracheotomy is done at the end of the procedure to prevent aspiration. The reconstruction is done with anterolateral thigh flap for this patient by our plastic team. I want to thank Mr. Nilesh, my colleagues Deepa and Gauri, and my residents. Thank you very much.
So any comments about doing tracheostomy or any laryngeal suspension? I think we have just exceeded by 4 minutes.
Madam, may I make a comment?
Yes, please, Sagar, go ahead.
Madam, it's a beautiful demonstration. Tracheostomy, like airway management and laryngeal suspension, is obviously very important, and we always follow the same protocol. Madam, I had a comment regarding preserving a cuff of gingival tissue on the lingual aspect. Especially, we get a lot of patients who have got submucous fibrosis, which involves the floor of mouth. So if you are trying to keep a small cuff of gingival tissue, falsely, it may the margin may be read as close or positive mucosal margin on final histopathology. And madam, another problem what it does is in a patient who has got submucous fibrosis and difficult, so insertion on the plastic team also becomes difficult. So inserting the flap into the remnant gingival tissue is a challenge. And in the post-radiation period, because usually these patients would require radiotherapy, there is a possibility of formation of an epithelialized tract, which can directly communicate with the neck.
So your points
So
well
I
taken.
usually take the lingual gingiva in toto.
Yeah, so the thing is, what I have showed, the reflected part of the mucosa should be taken, which is the fixed part of the gingiva. Usually I keep it because my thing is like whatever flap you do a free flap or you do any kind of a flap, the mandible does not get covered up by that. It starts sinking down whenever you give a radiotherapy, and that part of the bone remains exposed, and you get a osteoradionecrosis in that part if you don't have a gingiva over it. I know that you do a good resection and you do it around the dental thing. You may do some kind of a paramandibular thing, but the flap sinks down eventually once the edema is settled down. And I feel myself, I have seen plenty of patients where I have left behind, they do well. And but it is a kind of an individual opinion about it. And only epithelialized tract forms when you have a in continuity the epithelium going down. If you have sealed up the neck from the oral cavity, you don't get the thing. But yes, maybe the plastic team will love to remove every bit of mucosa. It's not a skin which is there, so it's only mucosa which will prevent that thing, and it doesn't get buried with the flap actually. Anyway, this is just a difference of
I'd like
opinion.
to add a
Yeah.
point in this.
Yeah, Asim, go ahead, please.
Ma'am, what happens is whenever we are taking the total glossectomy, when you are taking the gingival mucosa, one thing, remove the complete mucosa, and other thing, the use of knife. I would prefer using the knife because at times when we start using cutting and the coax current too much and buzz the entire mandible of the inner surface, that also causes a lot of problems. So it's better that we use knife just for cutting the mucosa. And second thing, whenever we are reconstructing using a free flap, a bulky flap, the part of the bulk which is densely or tightly adherent to the mandible surface is very helpful in preventing those leaks as well as subsequent osteoradionecrosis.
Yeah, great point, Asim and Sagar, and thank you very much. I think Poonam is just signaling me, and thanks, Poonam, for all the opportunity. I just exceeded by 7 minutes. I'm so sorry for that. Thank you.
Thank you so much,
Thank you, Arvind, and thank you, Sagar, Arjun, and everyone. Thank you.
Thank you, ma'am.
Thank you so much.
And please unshare the screen.
No, minute, please. Sincerely thankful to our expert panel for their thoughtful and incisive discussion of the topic. And I also appreciate Dr. Anuja Deshmukh ma'am for conducting this session with clarity and expertise. And our fourth session is a case presentation and discussion on carcinoma of the leaf. I now invite our esteemed expert panel for this session. Dr. Bipin T. Varghese is the professor and head of Department of Head and Neck Surgical Oncology, Regional Cancer Center, Thiruvananthapuram. Dr. Manu Malhotra, professor, Department of Otorhinolaryngology and Head Neck Surgery, AIIMS, Rishikesh. Dr. Apurva Garg is the senior head and neck surgical oncologist, Care CHL Hospitals, Indore. Dr. Mayur Mantri, professor, Department of Plastic and Reconstructive Surgery, Attrick TMC, Navi Mumbai. Our moderator for this session is Dr. Latika Kansal. He is the assistant professor, Department of Head and Neck Surgical Oncology, Homi Bhabha Cancer Hospital and Research Center, TMC, Punjab. And our presenter for this session is Dr. Dhruv Trivedi. He is the third year resident, Department of Head and Neck Surgery, Regional Cancer Center, Trivandrum. Dr. Dhruv, you can now share your screen.
Yes. Is my screen visible? Hello?
Yes,
Hello?
it is visible. It is visible.
Okay. Shall I start?
You can start.
Good evening, everyone. I'm presenting a case for today's discussion is carcinoma lip. So my patient is a 71-year-old female resident of Kollam, Kerala, a farmer by occupation. Patient had a chief complaint of growth over lower lip since last 6 months. Patient was apparently asymptomatic 6 months back when she developed the growth over lower lip, which was insidious onset. As per the patient said, it was in the midline initially, 1 into 1 centimeter, and now progressed to the current size. It was associated with pain, which was dull aching, not radiating, and relieved with the over-the-counter medications. Patient also gives history of bleeding intermittently around 5 to 10 drops per episode. It used to stop by itself, and last episode was around 5 days back. On elaborating further history, patient gives history of difficulty in speaking. However, there is no history of loosening of teeth, sharp teeth, decreased mouth opening, no history of numbness or altered sensation in the chin area, and no systemic history of difficulty in swallowing, cough, hemoptysis, bone pain, abdominal pain, or significant weight loss. Past history, there is no significant medical disorder or comorbidities, no drug allergy, no previous surgery, or no history of cancer. Patient consumes a smokeless tobacco around 2 to 3 times per day since last 40 years. Stopped 2 months back. No history of alcohol consumption. Patient consumes a mixed diet. Bowel and bladder habits are normal. No sleep disturbances. No history of multiple sexual partners. No IV drug abuse, and family history is not significant. So to summarize my history in brief, a 71-year-old female with no medical comorbidities and history of tobacco chewing habit presented with the growth over lower lip since 6 months, which was associated with pain and on and off bleeding.
Dr. Dhruv, you can stop here.
Yes,
So I want to ask you just go back to your history of present illness.
Yes, ma'am.
So you have not mentioned which part of the lower lip, whether it's a mucosal or the dry vermilion, where is the exact growth was present?
Okay. It actually was initially with the mucosal lip, but if we will proceed further, currently the entire lip as on the presentation was completely involved, ma'am.
And why this is important?
Because ma'am, mucosal lip comes under carcinoma oral cavity, and vermilion lip comes under a cutaneous non-melanomatous malignancy of the head and neck, ma'am. That's one of the factors.
And what are the other etiological factors? You have mentioned tobacco chewing, and what are
Yes,
the other
ma'am.
etiological factors for carcinoma lip?
Ma'am, patient is farmer by occupation, so the most important etiological factor would be ultraviolet radiation sun exposure, continuous sun exposure especially, or intermittent based on continuous exposure has more propensity towards the squamous cell carcinoma types, and intermittent exposure with the strong intermittent exposure, sun blisters are more associated with melanoma or basal cell carcinoma. The second important thing is herpes simplex virus infection, madam. Chronic herpes simplex virus infection recently in 2024, in the International Journal of Dermatology, they evaluated 5 lakh patients with the propensity score matching, and they found out that the odds ratio for overall head and neck cancers to be around 1.9, and for lip cancer especially, the herpes simplex virus relative risk is around 3.45. One more factor is history of burns and chronic mucosal irritation. These are the etiological factors that can predispose towards the malignancy of the lip, ma'am.
And any pre-malignant lesion that can turn into a malignancy?
Ma'am, lichen planus, but the percentage of it being converting to malignancy is very low, around 1. So that is one of the common over the area, ma'am.
What about the reverse smoking, Dr. Dhruv, and actinic cheilitis?
Actinic cheilitis, sir, with if the patient actinic cheilitis mainly comes near the angle of oral commissure area. So that has a propensity in to around 3 to 5% cases is also one of the predisposing factors for malignancy, sir.
And you have not mentioned that which part of the lip was affected initially,
Yes, sir.
and how the growth has progressed and to which part it has progressed in the meanwhile.
Yeah, Dhruv, you could also explain what constitutes the lip. You
Yes,
said
sir.
that it could be skin cancer also. So how do you
Yes, sir.
differentiate
So,
skin cancer
sir,
from a lip cancer?
dry vermilion is a part of considered to be a part of the skin, and mucosal vermilion or a mucosa, which is a part of the considered in the staging of as per AJCC tradition, considered in the oral cavity. So that is there, sir.
So it is the lower lip that is involved.
Yes, sir.
So which part of the lower lip, it started in the center or it started laterally? Commission
It
is involved
started
or
in the
not?
center, sir. Currently, it is the entire lower lip is almost.
Hello.
Yes, sir.
Then what are the symptoms that point out the nerve involvement, the mental nerve involvement?
Sir, a patient doesn't have any history of numbness or altered sensation in the chin area. In case of the disease is infiltrating downwards, involving the mental foramina or the mental nerve, usually there will be a paresthesia or a shooting pain towards that altered sensation over the chin area.
Okay. So that you said that the lower lip is involved.
Yes, sir.
So is there any difference in prognosis with the involvement of lower lip and the upper lip?
Yes, sir. Upper lip has a considerably poorer prognosis less than the lower lip, because upper lip nodal metastasis propensity is slightly higher, and those nodal metastases can go into the intraparotid nodes also. And the lower lip has a more predictable lymph nodal spread from the, if it is midline, can go to 1A, or if it is a lateralized lesion, it can go to 1B. So upper lip as well as the commissure has a are notorious for having a slightly poor prognosis than the lower lip, sir.
Okay, I think you can now proceed on to the next step.
Okay, sir. So, general physical examination, patient is moderately built and nourished, performance status ECOG 1, afebrile, BMI is 23 kilograms per meter square, pulse rate 72 beats per minute, blood pressure is 110/70 millimeters of mercury, no paler or generalized lymphadenopathy. Coming to the local examination, on inspection, orodental hygiene is poor, mandible is dented, no trismus, inter-incisor distance is around 35 millimeters, and there is a tobacco staining of the teeth. There is also a ulceroproliferative growth of around 6 into 3 centimeter present in the lower lip, involving wet and dry vermilion both, and going extending towards the labial mucosa, reaching up to left oral commissure, and on inspection, the right oral commissure is free, which is around 0.5 centimeter from the right oral commissure. It's away from the, however, it is reaching the gingiolabial labial mucosa. It is away from the gingiolabial. Buccal mucosa is also free. The surface of the ulcer is, as we saw, it's irregular, rolled out edge. It's bleeding. Oral cavity and oropharynx is normal. Skin of the chin, there is no ulceration, fungation, sinus formation, or edema or swelling. Basically, the skin of the chin is normal. It's confined to the lower lip proper. On palpation, I confirmed my inspectory findings. The tumor is 6 into 3 centimeter. Gingiolabial sulcus on palpation is also free. On palpation, the induration is reaching up to right oral commissure. There is no loosening of teeth. There is no loss of sensation in the menton area. Rest of the oral cavity and oropharyngeal examination is normal. On examination of the neck, there was no obvious swelling noted. Skin was normal, no scars. Laryngeal framework was normal, no thyroid enlargement. But on palpation, there was a right level 1B node, which 1.5 into 1 centimeter in size. It was firm, mobile, and it was non-tender. normal, and video laryngoscopy was within normal limits. Systemic examination also within normal limits. To summarize my case, a 71-year-old female with the no comorbidities, history of tobacco chewing habit.
Is that lady coming today for dinner?
She is on leave, I think, till 4th.
No? Yeah.
Ulcerative lesion of 6 into
I just I was thinking for some time. I don't. Can you join? आप लोग दोनों आएंगे मेरे हमारे यहाँ डिनर के लिए?
ulcerative lesion of 6 into 4 centimeter in the lower lip, extending up to bilateral oral commissures with on and off bleeding and pain, and palpable 1.5 into 1 centimeter lymph node, which is mobile, firm, and non-tender in the right level 1B.
Okay, Dhruv.
Yes, sir.
Once you have mentioned the complete examination findings,
Yes, sir.
let us understand that what are the boundaries of upper and lower lip? How do you define them?
Sir, upper lip, its oral commissure is the lateral boundary, and upper lip, laterally there are basically two units. The central unit has a columella, and there is a lateral unit. And for lower lip, according to the WHO, the extension of the nasolabial folds, which merges towards the lower lip, that is the lateral boundary of the lower lip.
Sorry to interrupt you, Dhruv.
Yes, sir.
What is the upper extent and the lateral extent of the upper lip?
Upper extent of the upper lip is it's a nasolabial crease, sir, reaching towards the ala of the nose, and
And that is
lower
the
extent
lateral
is the
extent.
septum.
So
Lateral
if you go up the philtrum,
yes, sir.
so nasal sill is the upper extent and the lateral extent is the nasolabial fold.
Nasolabial fold, sir.
Correct. So let's now talk about the lower lip.
Yes, sir. Lower lip, sir, the lateral extent is the where the our nasolabial folds merge down there, and inferior limit is the chin skin, and the upper limit will be the junction between the upper and the lower lip, sir.
So AGCC staging, particularly T staging, as you have mentioned, it emphasizes on two types of measurements which will change the stages, T stages. So one is the dimension, as you have mentioned. The other is the
For if the tumor is extending, if we consider, since this is a wet vermilion tumor, then it will be a depth of invasion will be part of oral cavity staging. It is not there for our cutaneous malignancies, cutaneous non-melanomatous malignancies. It's according to size or the T4A, T4B, but depth of invasion is the major difference between oral cavity versus the cutaneous malignancy, non-melanomatous malignancy of the head and neck, sir.
correct. So what if the tumor is crossing the border of vermilion? Then how will you say, when will you say the tumor has crossed into a small tumor of 2 centimeters has become T3?
A small tumor of 2 centimeters
Less than, sorry.
Becomes a T3 if it is a deeply infiltrative tumor, sir, based on the if we palpate the base with the bimanual digital palpation, we can assess the if we are feeling that the depth of invasion is coming more than 1 centimeter, it might become a T3 lesion. Or if it is a wet vermilion coming outside and infiltrating inside to outside, then it will become a T4A, sir. Or if it involves the bone inside back, then it will also become a T4A.
So far, you have mentioned the findings of your examination. You have
Yes, sir.
also mentioned the findings of the neck.
Yes, sir.
Right. So what will be your next step if there is no other question from the experts?
I just like to, Dr. Dhruv, can you read your staging again? I think you have made a small mistake there.
Sir, staging I have written as a clinico-radiological actually, sir, which was CT scan was done for this patient, and the node was found to be reactive kind of a node. So, sir, this was a clinico-radiological staging which I have mentioned, sir.
Okay, yeah, if it is palpable, then you can mention it as
Okay, sir.
yeah, no problem
Sorry,
on
sir.
that. Please continue.
Sir, I would like to confirm, proceed with the tissue diagnosis for this patient. I would like to take a punch biopsy, punch biopsy, and based on the histopathology report, I would like to also do a cross-sectional imaging in the form of contrast and CT scan of head, neck, and thorax, sir.
Dr.
Okay.
Dhruv, you can proceed with your CT scan.
Yes, ma'am. So this is a contrast enhanced CECT. I am going from above down craniocaudal direction from the head to neck. It is this is axial scan section, and it is a 0.5 millimeters of the cuts.
Dr. Dhruv, before you tell us the exact findings,
Yes,
would
sir.
you like to tell us that what are the things we should be looking for and emphasizing while looking into the scan?
We should be looking for the sir involvement infiltration part, whether it's reaching towards the mandible or not, because that will also help impact our decision making for a surgical as well as whatever the plan is made for the patient, as well as if the disease is reaching towards the mental foramina or not, whether in deeply infiltrating tumor. But however, my patient is not giving history of paresthesia or the mental skin, and chin skin is also normal. So unlikely that disease is reaching towards the mental foramina. As well as I would like to assess the nodal status for this patient. Usually the midline lip goes to level 1A, then bilateral level 1B also already. And we will assess the lower neck nodal status if any further lymph nodes are present or not, and screening CCT thorax for if there is any metastasis, and is there any second primary also or anything else in the scan that we would like to assess for our clinico-radiological staging.
Can you tell us the incidence of nodal metastasis and systemic metastasis in lip cancer?
Sir, nodal metastasis is around 15% at the time of the presentation. Sir, if it is a locally advanced disease, T3, T4, for early stages, it is very less likely. And distant metastasis, sir, I could not came across any specific data for lip and a distance metastasis. But if we see oral cavity per se, there is a chances less than 5% only, sir, metastasis. But I am not sure about lip and the distance metastasis data, sir.
Okay, we can proceed on with the CT scan findings.
Yes, sir. So this is contrast enhanced CT scan of axial section coming craniocaudally, 0.5 millimeters of the cuts of the CECT, oral cavity, neck and neck. If we go down nasal cavity, maxillary sinus, everything is okay. There is no lesions in the nasopharynx. Hard palate, soft palate seems to be normal. Now, if you see, there is a left side, there is a enhancing lesion just slightly towards the left. The enhancing lesion, the component of the tumor is started. Oh, sorry, it stopped. Tumor is starting, and if we go further down, the tumor seems to be well away from the mandible, and there is a lymph node which was palpable on the examination, which is this lymph node we could trace, which was right level 1B, which was palpable, but however it is a flat kind of a node with no contrast enhancement and preserved no central necrosis. Lower down, there are small bilateral reactive nodes, however no significant nodes we could see. This is the scan findings, sir.
Dr. Dhruv, when will you advise MRI in the case of CLA?
MRI in the case of CLIP only if there is a locally advanced stage when there is a perineural invasion we are suspecting, or if there is a lower lip adenocarcinoma or salivary gland origin which has a more propensity for a PNI. Such cases with the locally advanced status, we may advise for MRI. But however, we usually do at our center is a CECT first for the patients, ma'am.
Dhruv, can you just explain how does the tumor, the pattern of how does the tumor advance or pattern of local spread of the tumor?
Sir, it can go downwards to and infiltrate the orbicularis oris muscle and goes towards the chin, come out of the chin area, or it can go towards the gingiolabial sulcus and extends towards the mandible, as well as laterally it can go into the go towards the site of mental foramina and can infiltrate the neurovascular bundle in the mental foramina. And anteriorly it can come out, or laterally it can go to the involve the commissure. As in our case also, the commissure on the bilateral side is involved, sir.
Yeah. What are the peculiarities of lower lip malignancy, lower lip cancer against that of an upper lip?
Sir,
When you say
lower
local
lip,
spread, there is also distinct nodal spread pattern.
yes,
And,
sir.
yeah.
So upper lip, sir, has a nodal basins in the intraparotid as well as the infraauricular parotid nodes also. Whereas the lower lip is more predictable. Midline, it primary goes into level 1A, and lateral lower lip lesions can usually drains into 1B, sir.
Yeah, submental is more for the lower lip and submandibular is for the upper lip. And also, what about the bilaterality? Which one is more prone for bilateral lymph node metastasis from the beginning?
Usually, upper lip midline lesions have a by default more tendency for a metastasis of the lymph node. So I'm not sure about the data, but considering metastatic rate, lymph nodal mets are high in the
Yeah, that
upper
is
lip.
high, of course
Upper
high.
lip would
But
have
what
a
we are talking
bilateral.
about is the bilaterality, whether upper lip or the lower lip has got more of bilaterality, and what is the reason for that?
I'm not sure about that, sir.
Basically, it's because the lower lip has got more of lymphatic crossing from the middle because of the embryologic origin, because it has got a midline fusion, whereas in the upper lip you have a two midline, there is a frontonasal process and the lateral maxillary process. So it is something like a two partition. So it is usually it drains to the ipsilateral nodes where for the upper lip, whereas for lower lip you can have more of bilateral. That is what it is. Yeah.
Okay, sir.
Dr. Dhruv, is there any indication for doing a PET scan in such cases?
I would not like to go for a PET scan, sir, unless I have a N2 or N3 disease on clinical palpation. In such cases, or if there is a significant infiltrating bone erosion and advanced nodal metastatic stage, in such cases, I will consider for a PET scan. Otherwise, sir, for this case, being it clinically T3 stage 3, I would not proceed.
Good.
Okay, though if there are no questions, you can go ahead and mention how you're going to approach this.
Sir, I would like to give this patient a curative intent of treatment in the form of followed by adjuvant treatment based on my final histopathologic report. In the part of the surgery, I would like to do a wide local excision of the lesion along with the bilateral selective neck dissection clearing level 1, 2, 3. And in the form of reconstruction, I would like to give patients an option of a free flap in the form of radial artery forearm free flap with the palmaris sling tendon. That would be the plan of the action for this patient, sir.
Yeah,
and then adjuvant treatment based on the final HPR.
yeah, that is.
Dr. Dhruv,
Yes,
you
sir.
have been stating about the management of the current treatment. Let's go back in the stages
Yes, sir.
and let's talk about lower lip. So, what are the factors in lower stages cancer and higher stages cancer of the lip? And particularly talking about the lower and the upper lip, what are the factors we should be considering in mind before we make decisions?
Sir, for early stage cancers, T1, T2, lip malignancies, and also if the commissures are involved, such cases it is difficult to reconstruct and patient will have more functional morbidity. Such cases can be considered for an interstitial brachytherapy also.
No,
Or
I'm not asking you directly the modalities.
okay, sir.
I'm asking you
About the
what are the factors that influence our decisions? What are the things that are important to us? Let me point out to you
Yes, sir.
that it is the oral competence,
Yes, sir.
the chance of microstomia,
Yes, sir.
the sensation preservation, the sphincter continuity, and the aesthetics.
Yes, sir.
Right? Am I right?
Yes, sir. Yes.
So now after this, you can actually classify your algorithms as per the site of the initial tumors and the size of the initial tumors.
Yes, sir.
So if you have a lower lip involvement, which is less than 1/3 of the lip, centrally located or laterally located, approaching commissure, not approaching commissure, or if it is more than 1/3 of the lip, 2/3 of the lip, or more than 2/3 of the lip. So would you like to classify the reconstruction approach in this manner? Let's
Yes,
be
sir.
focused at the lower lip first.
Yes, sir. So for the lower lip reconstruction, sir, if the defect is less than 1/3 of the defect is less than 1/3%, then we can we can take a wedge resection or a W resection and close the defect primarily, sir. If it is more than 2/3 of the 1/3 to 2/3 of the defect, we can do a bay or a slander's flap depending on the central defect. If it is a central defect, a base flap, or if it is a lateral defect, we can do the slander's flap. If it is a more than 2/3 defect, then we can consider this patient for a Bernard's burrow triangle, basically advancement of the nasolabial skin to close it, or we can do a carapansdic flap, but the carapansdic flap will have a good competence, but that will create a significant microstomia, sir. And pertaining to this case, this is almost a total lower lip reconstruction. I would like to like a free flap in the form of a radial free forearm flap with the palmar sling for the dam effect would be for this case, sir.
Dr. Dhruv,
Yes, sir.
so you said the percentage is 1/3, 2/3. What
Yes,
are the factors which are important to see before you decide on the reconstruction? Say a young patient versus an old patient with 50% lip defect. Will your reconstruction remain the same, or there are factors which you will consider while planning this lip sharing procedure? For example, if there is a 70% defect,
yes,
whether
sir.
to do a lip sharing or you want to add a tissue, what factors would determine that?
If the patient is young, sir, more of a cosmetic concern, then I would not like to do this carapansdic or such a cosmetical like microstomic procedures. In that case, I would like to replace the tissue with the local flap, like a Gillies Gates flap or a bilateral nasolabial flap. I would like to do in such cases, sir, if it is a full thickness defect, sir.
No,
So
the
age is
question
one
was,
thing.
is there a scope for lip switch at all in this case? That was perhaps the question, is it? You have planned talking about, just mentioning about lip switch, was it?
Lip lip sharing, sir, for this
Lip sharing, yeah, that.
staging.
So lip sharing means how do you do the lip sharing for a lower lip defect, which is almost like 2/3 of the lip? Is it possible to bring in?
Third, if it is reaching up to 2/3, sir, lip sharing will not be for a upper lip defects. A lower lip sharing is more of a option than a, because of the lower lip has a more laxity. So, but upper lip laxity as the lower.
The same point which I was
For such
mentioning, because
cases,
your lower lip, you can afford to borrow more tissues from the lower lip and bring it to the upper lip for a
yes,
defect.
sir.
Whereas the reverse is not true because the symmetry is lost and it is bipartite. So
Yes,
that is
sir.
the reason. So what is the option in terms of locally available tissues once you resect?
There is one more technique, sir, that is a step ladder technique. If it is a midline defect up to like 1/3 to 2/3, but still that will also create some form of microstomia, sir.
Okay, so you can mention what is the kind of reconstructive option that you're going to bank upon in a situation like this. First, you have to give a description of the defect that ensues, and then what would you do?
It will be a total lip reconstruction, sir. For such defects, there are two options. I am offering this patient a free radial forearm flap with the palmaris sling. The second option is the Gates flap, which is a bilateral nasolabial flap, rotating and keeping it to construct the entire lower lip. So this would be what my plan is based on the patient's uh, discussion with the patient.
So which one is better, you think?
Cosmetically, better will be, sir, obviously free tissue transfer, because there will be no major nasolabial facial scar. But however, uh, this patient most likely receive a post-op adjuvant treatment. So radial artery forearm free flap doesn't have that much of bulk, and post radiation there is a significant amount of tissue loss. That is also one of my concern. But if any other flap, then there is a middle forearm, a middle arm free flap, which is I have read
Lateral arm. Is that
lateral
what
arm flap, which gives in between gives the bulkiness in between the radial artery and the AIT. So that, but I could not find for more literature on that flap, sir, for this lip defect.
So, if you do a radial artery forearm flap, how will you maintain the competence of the patient? What will you do for that?
Sir, palmaris sling tendon, I would like to take and suture it along the commissure like a braid U-shaped closure, and that will give some amount of dam effect to the patient for this.
So, both the commissures are being excised, you said, no?
Yes, sir. Yes.
So, in this
So for our
situation,
wide local excision, it will go, sir.
so it is difficult to then fix the PL sling to the orbicularis muscle in such
Yes, sir.
situations if there are both the commissures are gone. In that situation, usually
Yes,
you
sir.
fix it to the zygoma bone and form a hammock kind of thing,
Okay, sir.
because otherwise there will be a lot of microstomia.
Okay, sir.
So what I was meaning to ask previously was, so not in this case, because this is a 100% lip defect, you don't have much choice. But for say
Yes, sir.
60-70% defect, if you have an option to give microstomia and give oral competence versus giving a macrostomia and incompetence, how will you choose whether to give a microstomia or a macrostomia and incompetence? What factors would decide that?
Which one is better, macrostomia or microstomia? That's the question.
I would like to give competence. We have to balance both, sir, but competence over incompetence is what my thought process is, sir.
So there are factors that you have to see if the patient is dentate or edentulous.
Yes, sir.
Whether patient has submucous fibrosis, because if he has submucous fibrosis, anyways, the mouth opening is not much. So in that case, you can afford to give microstomia. But if the patient has good mouth opening, is dentate, then you are towards giving a macrostomia so that the patient, and then you can maybe correct the macrostomia later, which is easier to correct than to correct the microstomia.
Okay,
That's
sir.
the point.
Yes,
So if you have a little bit of macrostomia, that is always correctable later. Whereas microstomia, it's more difficult to.
yes, sir.
Dr. Dhruv,
Yes, sir.
in this case, you have planned for a free radial forearm flap.
Yes,
So,
sir.
would you like to give any instruction to the patient before she leaves your OPD?
Instructions, sir. For a free radial forearm flap, there is a if we are taking palmaris tendon also, and she is a farmer, so she will not be the restriction, the contracture develops. So donor site is little morbid. So I would explain that patient that there will be a difficulty in her day-to-day return to job also.
Right. And one more practical tip, just ask them to keep the left hand free, because many times what happens is that when patient go for pre-op investigations, so they invariably withdraw blood from the left hand.
Yes, sir.
So because I have seen sometimes the vessels may get thrombosed. So just be careful. If you plan prep from the beginning, just ask them to keep the left hand free, no prick.
And any examination that you would do?
Allen's test we will do to confirm the collateral supply from the ulnar arch, sir, palmar arch.
Yeah, and also you will check for PL if it is present or not.
Yes, sir.
So, Dr. Dhruv,
Yes, sir.
What decisions, how will you decide on to the neck, management of the neck?
Consider to be a T3 disease, sir. I would like to do a end crossing midline, entire lower lip is involved. I would like to do a bilateral selective neck dissection, sir.
So here you have pointed out that it is clinically N0. And for clinically N0 cases, if it is a T2 lesion, if we assume, is
Yes, sir.
there any role of sentinel node biopsies?
Yes, sir. We can do intraoperatively the sentinel lymph node biopsy, and based on that, we can decide upon leaving the neck on observation also, sir. There are 3-4 trials which has been recently published, sir. SAINT trial, one French group study, then Hashigawa et al. Trial, and one is comparable analysis, which almost all the studies have a negative predictive values around 9. That is one good option for assessing the neck intraoperatively, sir, if it was a lateralized T2 lesion, sir.
Yeah,
So what
having
is
said
the
that, yeah, Dhruv, sorry,
Yes, sir.
did I interrupt, Dr. Manu?
Sir, please continue.
Yeah, so actually, having said that, if you have a sentinel node negative situation and you feel that patient is essentially N0, do you have a local, other local option which can be used based on the fact that patient is N0?
Yes, sir. If the patient is N0, the disease is lateral nears the, if it is little bit more towards the commissure, then alternate option, and patient is medically unfit. Such cases are not in early lesions. There is alternate. The good results are for both, sir. Interstitial brachytherapy as well as the white. So interstitial brachytherapy can also be considered for a patient which is a clinically T2. The results are 5 overall survival is around
No,
90%
no.
for both the
When you
modalities.
do surgery on a T2 bordering T3 disease,
Yes, sir.
similar to this, your node has become as negative based on your sentinel node technique that you have done. Do you have a alternate option other than the free flap and the conventional? I mean, most of the time we do nasolabial, it works out well. Can you, I mean, for a larger defect, can you think of combining with some other flap or some other technique for that matter?
For the mucosal Lip, sir, there is a stage procedure called mucosal advancement for a tongue flap or a buccal mucosa flap. So that also can be done from the ventral surface of the tongue. The mucosa is advanced and suture towards
No,
the
no. It's essentially
mucosal area.
here we are talking about a larger defect. So in this case, one more concern is well, you told that it's a total lip reconstruction, but
Yes, sir.
also you told that it is a proliferative lesion, essentially confined to the vermilion and the mucosal lip.
Yes,
So the
sir.
defect may not be as big as probably you might initially think of.
Yes, sir.
It is in that context that do you have other choice? Because there is a question also in the chat box. That's why I asked.
If I could interrupt, sir, we
Yeah,
are.
yeah. I was just. Uh, I mean, any other question is welcome. Just. I was just.
Sir, we are the short of time. So
Yeah,
I
yeah.
would request
We
to
need
rate
to wind
Dr.
up.
Dhruv.
So Dhruv,
Yes, sir.
so I will ask the other examiners also about your performance and if there
Uh,
is.
Dr. Manu, sir.
I think we have asked many questions, but the questions they have no end. So we will
Yeah.
stick to the time, right? And
Yeah.
the last thing that Dhruv can emphasize on is that the choice of radiotherapy as the adjuvant modality, what will influence the choice of radiotherapy, that we haven't discussed yet.
Yes.
Choice of radiotherapy, if indications, if I would mention if it is a T3 tumor for the final histopathology, a node positive case, or if there is a uh, any one single margin positivity, or if there is a high risk double risk factors like a perineural spread is there. Such cases, I would like to give this patient adjuvant radiotherapy, sir.
Okay, what is why when will you go for a brachytherapy?
Brachytherapy, sir, for a large lesions, if the patient is medically unfit, such cases there is the option of external beam radiotherapy with the brachy boost. So in that case, basically, instead of giving a 65, 67 grays of external radiation, they give 50 to 55 gray of external beam radiation, and during the towards the end of the session, they give the brachytherapy boost at the local site in the form of 20 30 fractions. That is one modality of treatment if this patient is unfit for a medical surgical intervention, sir.
And in the early lesions?
Early lesions are high dose rate brachytherapy. The evidences are coming up. In our center, we have a low dose brachytherapy we consider for T1, T2 lesions. That is, there is no RCTs to clearly state the advantage, but the retrospective data states that 5-year overall survival is around uh, the surgery versus the only brachytherapy for early lesions.
So let me ask you a very gross question in the end.
Yes, sir.
That you have an early cancer, T1, T2, and you have a late cancer. So which modality of the treatment, surgery or radiotherapy, increases the chances of survival?
For late cancer, sir, it is always surgery followed by adjuvant, which will increase the chance for overall survival. It's stage 3. And for early cancer, depends on the patient factors and also young patient who doesn't want cosmetic scar, or if the lesion is towards the commissure, those cases, both the modalities would give the same factor, but considering the neck should be N0.
Um,
Okay.
okay, sir. If there is no more question, we have to wind up the session. We are ahead of our time.
Thank you.
So, Dr.
Right,
Bipin
Dr.
sir and Dr. Purva sir and Dr. Mayur sir, please rate the performance of Dr. Dhruv.
I think Dr. Dhruv has performed pretty well since considering the cancers, lip cancers are not very common in India. And I would like to give him more than 8 out of 10.
Yes. I second your thoughts, sir. He performed really very well.
Okay.
I also agree with the professor. His performance was very good. I would also rate 8 out of 10.
Thank you, sir.
Okay. Thanks, all of you, because he's from my center. I'm not giving him marks. I think he's done well.
Sorry.
Thank you, sir.
Thank you.
So can you please stop yes, thank you.
And moderator for this session. We now come to our final and fifth session of the day, a panel discussion on tracheostomy, surgical considerations and implications in head and neck surgery. And I have the privilege of introducing the expert panel, Dr. Saurav Datta. He is the Director, Oncology, Senior Consultant, Head and Neck Surgical Oncology, Manipal Hospitals, Kolkata. Dr. Mural Dala, Consultant and Head, Department of Surgical Oncology, PD, Hinduja National Hospital and Medical Research Center, Mumbai. Dr. Pranav Ingole, Associate Professor, Department of Oral and Maxillofacial Surgery.
Our next speaker will be Dr. Pranav Ingole, Associate Professor, Department of Oral and Maxillofacial Surgery in Pushkar Ahilyabai Holkar Head and Neck Cancer Institute of India, Mumbai. And our final will be Dr. Karthik Krishnan, Associate Consultant, Department of Head and Neck Oncosurgery, Punya Shlok Ahilyabai Holkar Head and Neck Cancer Institute of India, Mumbai. And our speaker for this session will be Dr. Mitali Dandekar. Madam is Senior Consultant, Department of Head and Neck Surgical Oncology, Paras HMRI Hospital, Patna. Madam, please share your screen, madam. Ma'am, even if we don't...
So, good evening, everyone. And yeah, and thank you, organizers, for actually considering a topic like this and devoting a good 40 minutes, although we are running short of time. We also have a great, a knowledgeable and highly experienced panel So I'd like to extract a lot of their insights and experience into dealing with patients of oral cavity cancers with or without tracheostomy as per their indications, surgical tips with perioperative considerations, as well as methodology or the algorithm they follow for decannulation. So is that fine, all the panelists? I mean, we will begin, we'll take one topic at a time and dive deeper into it. Also, for a topic like tracheostomy, I would prefer if we took, what I have done is collated available literature with the cohorts-based studies which are available, and then we will pick each topic and take your expert opinion, if that is fine with you all. Yeah?
Yes, ma'am.
Sure,
ma'am.
So let's just begin. So as far as indications of tracheostomy, as all of us would know, is perioperative airway protection with regards prevention of aspiration and also providing a pulmonary toilet. In addition to that, obviously the most important being the patency of the airway. I'd like to draw your attention to the second diagram, which actually shows the importance of the genial tubercle as far as indications for tracheostomy is concerned. And we'll obviously discuss and take your viewpoints on this. The attachments of the geniohyoid, the attachment of the genioglossus, as far as the tongue is concerned, as well as the central arch of the mandible as far as buccal mucosa composite with central arch is concerned. So, a preoperative tracheostomy, the current scenario of preoperative tracheostomy, I was able to find a cohort study from the HCG Manavta group, and not to my surprise, majority, almost 92%, 92.4% patients underwent a total nasal intubation or some sort of fiber optic intubation, and the incidence or requirement of pre-operative tracheostomy for any of the reasons was less than 5%. Would the panelists want to share their experience on the requirement of pre-operative tracheostomy as far as oral cavity cancers are concerned? We'll start with Saurabh.
So, in my practice, we almost never do pre-operative tracheostomy. Almost all the time for oral cancer, our anesthesists, they do a fiber optic, and after doing the primary resection, neck dissection, we intraoperatively we do the tracheostomy whenever we are doing the tracheostomy. So pre-operative tracheostomy we never do. The basic thing is it's painful for the patient because you cannot give GA on local, and obviously there are risks more than doing in an intubated patient.
Correct. And also because there are techniques where you can manage an airway before giving general anesthesia is what probably you want to even emphasize on. Perfect.
Exactly.
Karthik, would you want to add anything to what Saurav has just said, or you agree with what he said? What would be your experience of performing tracheostomies pre-operatively to secure an airway?
Yeah, so good evening, everyone. So I agree with whatever Saurav sir said, that the indications of preoperative tracheostomy are almost nil nowadays with the fiber optic bronchoscopy available and the experience of our anesthetists. So the most difficult of difficult airways, they are able to do a endotracheal intubation in the oral cavity cases. We do keep a tracheostomy standby in case if the some desaturation happens during the intubation, but in my experience the requirement of such a scenario is like almost nil. We have never had any experience.
Pranav, would you want to share any unique experience that you have had?
Yes, ma'am. Just on a lighter note, means in my institute, a lot of time anesthetists say that go ahead with the pre-operative tracheostomy, but I strictly avoid because you never know, the next day patient might get fired because of n number of reasons.
So what I understand is even in your setup, you are
Yes, ma'am.
comfortable
Yeah, I'm
with
strictly against the preoperative
yeah,
tracheostomy.
our anesthetists are comfortable with
Yeah.
intubating difficult patients.
Yeah.
Murad Lala, sir, I think I'll get you in probably a couple of minutes from now because I want your expert opinion on probably the next point that I'm going to make.
Sure.
So let's then come on to a meta-analysis, a recent meta-analysis which was published in 2025, where they looked at requirement of tracheostomy in flap-based head and neck cancer surgery. A large cohort of patients, 26 studies with over 27,000 patients. What was interesting is the pooled tracheostomy rate they found was 54.6%. That is almost every 1 in 2 patients underwent tracheostomy, and it reduced about 40% after adjusting studies where they conducted tracheostomies for all comers, like 100% tracheostomy rate. All those studies were adjusted, and they found a realistic tracheostomy rate to be 42.4% in all patients who underwent flaps for head and neck cancer. What was more interesting is there was no significant change in tracheostomy rates in the past 3 decades. That means there were no temporal trends as such in the there was no change in the policy of performing tracheostomies. And here I would want to get Murad Lala, sir, considering your extensive experience of several decades, would you want to comment on whether there has been a change in the way you approach patients for tracheostomy?
I mean, as they said, in the last 3 decades, there's been no change. And I think that's the same with me also. In the last 2.5 decades, I don't think there's a change. I have preoperative tracheostomies. I don't think I have done any preoperative tracheostomies for any of my patients to date.
All right, sir. And as far as post-operative requirement, has what probably the way you would have approached the patient maybe in early 2000s and the way you're approaching now, has
Yes.
it changed or it has remained the same, sir?
No. If you're asking about intraoperative tracheostomy, again, I never do an intraoperative tracheostomy. And if you want me to discuss now, I'll discuss now. It's later on. I can discuss it later on.
I think, sir, let's hold that for the
Yeah.
So even for somebody as experienced as you, you feel there has been no change in the policy in the way you yourself approach patients as far as airway protection is concerned.
True. There's no change with me. And I think across the board also, at least by the literature that I read, I don't think, I mean, everyone talks about reducing the rate and it is marginally coming down, but there's been no significant reduction in the rate of tracheostomies.
All right, sir. Sure. Do any of the other panelists want to add to this? Has anyone seen a temporal change or trend in the way you all approach patients for tracheostomy after, during, before addressing perioperatively?
So if you, for me, definitely there is a big change because you say if you count my means residency to a practice, it is almost 1.5 decades. And for last 1 year, influenced by Murad sir, my tracheostomy number has slightly decreased. I will not say like Murad said, but definitely it has decreased.
So it has decreased because of an influence by or speaking to some expert in the field. Agreed. But
Exactly.
and we will come to that a bit later. Has the way your setup or the experience of your anesthesiologist or your support staff contributed to your decision making, Karthik?
Yes, definitely. So the institutional presence of your speech and swallowing therapist, good anesthesiologist, all makes a huge difference. So if you know that you don't have such infrastructure and you don't have a good ICU backup, you generally in nursing homes and all, you would do a routine prophylactic tracheostomy, considering that if anything happens to the airway, there is no one around to do an emergency intubation or tracheostomy. So in such cases, you would do a prophylactic tracheostomy tracheostomy. But in case if you have a good ICU backup and speech and swallowing therapist who give good swallowing exercises and prevent aspiration and all in the post-op period, then the chances of doing a tracheostomy intraoperatively goes down drastically. So definitely, as Saurav sir said, the trends even in my experience have changed a lot considering where I've been practicing. And with last year when we encountered Murad Lala sir's talk in Tata, we have also reduced our tracheostomy incidence.
So, safe to say that the infrastructure, the support system that you have also influences the indication for tracheostomy in largely the various kinds of setups that head and neck cancer surgeries are performed also have a role to play in the indication. So now let's then go back to the meta-analysis where they found that larger tumors, involvement of the oropharynx, bilaterality played a significant role as far as indication of tracheostomy is concerned. In addition to that, patients who had smoking history, patients who had prior treatment with radiation therapy also were significantly considered for tracheostomy. Bilateral neck dissections, interestingly, also evolved as one of the strongest predictors. Regardless of the confounding factor that the extensive tumor stage also were the ones who actually needed bilateral neck dissection, but regardless of that, bilateral neck dissection, they say, evolved as the strongest predictor. So if leave alone the fact that a large tumor needs bilateral. Now, there was a case, I think, which was discussed just before our session of a lip cancer, a midline lip cancer with bilateral multiple nodes and requiring bilateral MND. Would just bilateral neck dissection be an indication where any of you would consider tracheostomy? Now let's leave the infrastructure setup and the support system. Consider that all of us work in a support system, a good place which offers good infrastructure, which offers good support system. Let's look at just pure science and tumor and patient factors. Would bilateral MND be one of the indications where you would perform tracheostomy? Pranav?
No, ma'am. Only means the previous case, as you discussed, just purely neck dissection. Doing the neck dissection is not an indication until unless the primary tumor, which involves the floor of the mouth and the mandible. I will never go for that.
Anyone else has any other viewpoint on this? Saurabh?
I totally agree because I think means I was going through the literature and lot of articles have mentioned about bilateral neck, but I really think it is probably because when they saw the bilateral neck, because probably it is crossing midline, that may be the reason. But if it is a small lip tumor, a midline lower lip tumor or a tip of tongue small tumor, if I am doing the bilateral neck, I will never do a tracheostomy for sure.
So safe to say that the tumor factors take precedence over the extent of neck dissection?
Yeah, 100%.
Yeah,
Extent
100%.
of neck dissection is never, for me, it's never an indication for a tracheostomy.
Sure. So then let's move on and look at another article which looked at the airway management in patients who underwent microvascular reconstruction. And again, they gave us a sort of a flow chart whereby they said that look at the preoperative factors with regards to the patient as well as the tumor. Also, post-operatively, make a second assessment after before extubation to look at how the soft tissue, whether there's soft tissue edema, bulkiness of the flap, etc. And then consider, if anything, at least an overnight intubation, and then the next morning again make an assessment. I would like to bring in Murad Lala sir here and give us his way of assessment and how you have been able to decide upon reducing, or for that matter, not doing tracheostomy for most of your patients. What is your airway management?
So, yeah, my airway management is always intubation in this either direct with or fiber optic intubation. Post-operatively, I mean, although pre-operatively, I have consented all my patients for a tracheostomy, but my patients will be shifted out of the ICU, I mean, after the OT into the ICU with the tube in situ. Unless I have not done a flap, those few cases where we do either, a small skin graft or we have done a primary closure, then we extubate on table. And in fact, they go directly to the wards for a well-lateralized lesion. But otherwise, in case the patient has a flap, especially if it is a free flap, the patient goes intubated to the ICU, kept overnight intubated. The next morning, after I have seen, as well as our plastic surgeon has seen and confirmed the vascularity of the flap and is happy with the flap, that is then we do a extubation. Now, in case it is a lateralized lesion, we will directly extubate the patient, provided mouth opening is adequate. In case there is severe trismus, or if this patient has a bulky flap, or I'm little concerned, then I will probably keep the tube overnight for about 48 hours. So not the next morning, but after 48 hours, I assess the patient for extubation, and we will extubate these patients in a sitting up position, and we will put a tube exchanger and then pull out the tube. So the tube exchanger remains in for about 3 to 4 hours post extubation. And once we are very sure that he is comfortable, he's able to sort of cough out, or at least get it into the mouth and then suction out the secretions, then we will remove the tube exchanger, start the Riles tube feeds, and send him to the ward. So that is the protocol we follow.
So just one question. If Mitali gives permission, then I can.
One sec.
So,
yeah. So I just wanted to add and ask another question to that. So what percentage of your patients, after using a tube exchanger, what percentage of your patients then would require typically a re-intubation after, say, 48 hours?
Less than 5%. Less than 5%. And in case I re-intubate those patients, then I keep the tube in for another 48 hours and then again make an attempt for extubation. And invariably, we've been able to extubate these patients.
All right. All right. Yeah, Saurabh, sorry for interrupting.
No, that was the question.
Okay, fine. So then, all right. Does any of the panelists have any point to make? If not, then we'll just move on to the next point, wherein why is this not moving?
Yeah, but having said that, again, it is not that I am against tracheostomy. I am just saying that assess your local factors, assess where you're doing this, assess the support services available, then take a decision, okay? Because there's no heroics in saying that I didn't do a tracheostomy. I don't mean to sound like that, but if I still feel that we are overdoing tracheostomy, so if you have a good setup, or you know what you are around, and you know that this patient could be safely reintubated, I think we should not do a tracheostomy for that group of patients. And there is a school that says that for lateralized lesions, they will do a tracheostomy and within 72 hours decannulate that patient. I think especially in those patients, you don't need a tracheostomy if you're able to decannulate it within 72 hours. So I think it's more mentality that obviously that we are sort of hesitating to do it, but I think take baby steps towards it, and maybe we will significantly reduce our tracheostomy rates.
Yeah, I completely agree. Thanks for bringing in that point. So it's not that just because someone it all depends, like we discussed in the previous slides as well, that it all depends upon the entire your support system.
Correct.
Just one person rising up and saying, okay, from the next time I'm not doing a tracheostomy, I don't think that is going to work. I think it is to be a systematic effort by every individual who's involved in taking care of that patient. So yeah, thank you, sir, for bringing that point up. But let's just move on now. There's something called as tracheostomy scoring systems. The most widely used are these three, of which one of them has actually come up from our SCG group in Ahmedabad, wherein they've given typically scores based on the tumor site, stage, the need for mandibulectomy, the need for a double free flap, the need for bilateral neck dissection, and each component has been scored. Uh, uh, Interestingly, most of them have given a decent amount of negative predictive value, with the one which the HCG Ahmedabad group has actually given a negative predictive value of 99.3%. So do you think, do any of the panelists think that such a scoring system really is makes sense to actually standardize the whole process of whether a tracheostomy is needed or not needed. Let's start with, say, Pranav.
Ma'am, this means theoretically it might look good, but end of the day you have to take a lot of factors in consideration while to do the tracheostomy or not.
All right, and if what anything else apart from these factors that you would really
No,
you
ma'am.
know.
I think they have almost included all the factors.
Sure, sure.
No, but see, can I just come in here? They have not included your local infrastructure. I think that is very important. You know, if you're doing this in a if you're doing this in a nursing home, where I would not agree with this. They have not included all the points. I think a very important point is the local infrastructure and the local expertise, and that has not come into any of these scoring systems.
Yeah, support system.
May I? Hello?
Yes, sir. Please come in.
So for me, I was going through all the scoring system, and I don't think any one of us is following it. If I say I don't think means almost these are theoretical, what Pranav said. But for me, in my practice, there are 4 factors which is for me important for my decision making. One is my primary surgery. Means, as you have told, if I am breaching the genioglossus geniohyoid, I am not comfortable not doing tracheostomy. This is number one. Number two, in palatal defect, if I am crossing the midline and during surgery, if there is a chance of hitting the nasotracheal tube, uh, then I will probably do a tracheostomy, then do the maxilla. This is one, and there are some, if there is extensive trismus, these are the factors. Second factor is from plastic. So from primary surgeon, second is plastic surgeon. A lot of time, if there is a very bulky flap, then it is, I am not comfortable of not doing the tracheostomy. And at the same time, if in any situation, if my plastic surgeon is saying that his vessels are very bad, atherosclerotic, I am assuming that there may be fab related complication, re-exploration. I will be comfortable of doing the flap. Third factor is anesthetist point of view. If my anesthetist is saying that this patient has major cardiac problem, these patients may be difficult to intubation, and anything if goes wrong during extubation, then there may be a problem. In that scenario, I will go for a tracheostomy. And lastly,
sorry, go ahead. Sorry.
And lastly, in ICU, if my interventionist is saying that in extubation he is feeling some problem, then I may do. But this scoring system that bilateral neck, T size, I really don't think.
Just if I may summarize, you typically included patient factors, you included the tumor factors, you included the flap factors, and you included by and large post-operatively if there's a difficult extubation. If that is the way you would want to summarize it. Perfect. So then one thing that I wanted to just emphasize is all these scoring systems also considered, apart from the fact that there was obstruction of the airway, the fact that the patient could develop aspiration post-operatively by including oropharynx and giving a higher score for the oropharyngeal involvement. Like even Saurabh said, anything which crosses the midline as far as the palate is concerned. So, Karthik, may I bring you in here? Apart from involvement of the oropharynx, is there any other factor which makes you feel worried about potential aspiration and you would want to do a tracheostomy preemptively as for a pulmonary toilet?
So, ma'am, it is mainly in the central arch mandibulectomies where your tongue support goes. So, your tongue can fall back also, and even they lose the whatever the tongue is able to prevent aspiration, that function is also lost. So, in those patients, I tend to do prophylactic tracheostomies when I remove the central arch.
So central arch again, Karthik, I think even Saurabh made this point, would be the genial tubercle complex is mainly for obstruction of the airway more than, actual aspiration. So the moment you breach the base of the tongue, probably I think, or probably involve the lateral pharyngeal wall, the issue of aspiration is what we all of us would fear here. And Murad Lala sir, do you want to make a comment on this?
Yeah, so I have not done tracheostomies for the central arch, even when we've done central arch mandibulectomies and the genial tubercle is removed, because we always hitch it back. I mean, we've always done a free flap for these cases, and we always hitch it up forward again with a non-absorbable suture around the free fibular graft. So I have not had an issue about tongue fall in this group of patients, so I wouldn't agree to that. As what are the other points Saurav had brought up? One was this central arch. Saurav, what was the other point? Post-op. So the other thing is in the ICU, we always have the facility for again a fiber optic intubation. So I think
Sir,
that is important.
Sir, I don't know, but I am not comfortable of not doing tracheostomy in a palatal dissection when I am crossing the midline and my tube is on the opposite side, because hitting the tube and leak, this may be a catastrophe.
Correct. So again, hitting the tube and causing a leak, that means preoperatively, I mean, sort of intraoperatively, before you're excising, you're putting a tracheostomy tube, right?
Yes.
Okay, no. So again, even for palatal lesions that are crossing the midline, I don't do it, and I'm acutely aware that the tube is there. And in fact, I have the tube exchanger and I have extra endotracheal tube, and I inform the anesthetist when I'm crossing the midline and making my cuts. And to be honest, it has happened once where I have injured the endotracheal tube. So immediately we put in the tube exchanger and change the tube. So it has happened. It's just that we are acutely aware of it. We have the thing standby, and our anesthetist also is informed whenever we are crossing and making our cuts over there. So again, that's how I prevent I don't do a tracheostomy in that group of patients.
All right. So I think moving on, would any of the panelists want to contribute on any indications which were not previously discussed, or should we carry
So one of the indications which has not been discussed, again, which I don't do it for, but one of the indications is those patients that have had prior radiation therapy or recurrent cases.
Scoring systems and across all scoring systems as well as the meta-analysis, post-RT is one of the higher rated.
Yes, post-RT, or recurrent tumors.
Absolutely. Yes, that has been considered in almost all the previous
scorings. Yes.
Yes. So again, so I think we got enough tips from Murad Lala sir as to how we could avoid or the risk adaptive alternatives that are available in patients who we do not want, or defer tracheostomy, that is delayed extubation that we just heard from him. Any role of tongue stitch in patients who probably lost the genial tubercle? Karthik, Saurabh, Pranav?
Yes, so in major glossectomy cases, as Murad Lala sir said, we also practice taking the stitch and anchoring it to the hyoid. So that does help in early decannulation of the patients. We don't avoid tracheostomies prophylactically, but it helps in early decannulation.
Or you mean to say intraoperatively while stitching? What I mean to, the question mark was for the tongue stitch postoperatively when attempting an extubation.
Yes, ma'am. Even in my practice also, we remove the tongue stitch after 2 days only. Means.
Also, you take a tongue stitch?
Yeah. We keep it even in the ICU. Means after 2 days we remove it.
Yes, my patients also have the tongue stitch in situ. We don't hitch it, but it's just hanging there, and only after extubation do we remove the tongue stitch.
Yes.
All right. So then let's just move to the next aspect as far as reported complications of tracheostomy are concerned. I'd just like to enumerate 2 studies which have looked at it. In fact, the first study is the meta-analysis, which was dissected before. where the pool complication rate reported was approximately 16.3%, including chest infection, wound infection, bleeding, dislodgement of the tube, and stenosis. Similarly, in another study as well, I think the study was from a government college, Patiala, wherein the complication rate and the various complications which were reported, maximum of which was obviously tube displacement or blockage, but there were significant number of patients who underwent emphysema, pneumothorax, hemorrhage, apnea, difficulty cannulation, and tracheal stenosis. My question to the panelists is, how often, amongst the ones who have undergone tracheostomy, how often does one really experience these complications in your practice? Let's start again with Saurabh.
So, chest infection happens to few patients. I don't know whether it is due to the intubation or due to the tracheostomy, so I cannot categorize for this. Wound infection, very, very rare. Sometimes if we take chalk stitch, and sometimes if the sister she has not been able to pull out the entire thread, a bit remains. Sometimes stitch granuloma happens. That's all. Bleeding, very, very rare. We are very much meticulous about securing all, even if small pain. But yes, I think once we had to take the patient in the OT for bleeding from the tracheostomy site. I think once we have to do it. Stenosis, never we have encountered. Uh, Dislodgement also not, but I would rather put two other things. One is uh, very rare cases, non-closure of tracheostomy is a problem, very rare though. And second is the main problem of tracheostomy is tube blockage. If you don't have the experience stuff, if there is no proper suctioning, though we always use double lumen tube, but still there is once in a while tube blocks is a major complication, life-threatening.
That the maximum, I mean, all of us who've done tracheostomies would experience tube blockage, would rate tube blockage as one of the highest complications that we encounter. But really, bleeding or wound infection or emphysema is something that is very, very rarely seen, particularly because as experience grows, such situations really very rarely occur. Karthik and Pranav, would you want to add to this?
No, ma'am. Only the tube blockage is the nightmare.
Yeah. So, sir, Murad Lala, sir, here I would want to bring you in. So they've said something like chest infection as a complication of patients who undergo tracheostomy. The corollary is what I would want to ask you. Amongst the patients who have undergone delayed extubation or oropharyngeal, like a base of tongue excision, would there be any patients who would experience aspiration pneumonitis in the post-operative period?
We've never had anyone with severe aspiration pneumonitis, but yes, there is minor pneumonitis that happens occasionally. We have seen it. But the other side, what I want to say, which maybe again is theoretical. I don't know whether this is true, but when you do a tracheostomy, in a way, you are splinting up the trachea over there. So that also contributes to aspiration, and that also contributes to swallowing difficulties post-operatively. Your swallowing rehab may take longer.
Sure, agreed.
This is not objective, but I probably this happens.
Yeah. Do you bring in your swallowing therapist maybe immediately after extubation in order to avoid that aspiration pneumonitis?
Aspiration, yes. So the speech and swallowing person is actively involved, and so is our nursing care, and so the registrars who keep making rounds, and we keep thumping the back. The usual physiotherapy goes on. That is important. And we start swallowing only once our swallowing therapist is in front of the patient, counsel to the patient, and the first sips are always taken with the swallowing therapist over there.
So, we need to re-emphasize the fact that, needless to say, care of the patients is a interprofessional or interdisciplinary approach is necessary, whether you do a tracheostomy or you do not do a tracheostomy. Regardless of that, it has to be a multi-pronged approach. Let's just move on. And can we conclude from here that yes, there could be complications, but they're very extremely rare and very, very one of kind across all panelists? Is that shall we move on with this to the next slide then?
Yeah, 100%.
So rare complications, but all of us agree that it has significant psychosocial implications as far as patients who require tracheostomy for a longer time is concerned. So that is the reason why we need some good surgical tips and good post-procedural care, and that is what we would want to extract from our panelists now. So level of skin. So consider, even Murad Lala sir, please consider that suppose your patient is undergoing a tracheostomy. We would want your opinion on the level of skin incision, vertical versus horizontal.
I do horizontal incisions.
I also.
Yeah, I don't take vertical incision. It would be a horizontal incision.
Completely agree. Anybody else has another viewpoint on this?
No.
Okay. So even in patients who undergo bilateral neck dissection, a horizontal incision is good enough. I mean, one does not need to change the incision just because the patient has undergone bilateral neck dissection. But care must be taken that after tracheostomy, there is no communication with the rest of the neck, because that would lead to wound contamination and the drains would not hold. And hence, it's a good practice to always, before closing the patient, verify whether that there is a communication with the tracheostomy site or no. Then let's move on next to the site of tracheal incision. Any preference? As all of us agree that we perform by and large between the second and the third tracheal drain.
Yes.
Any indication in oral cancer surgery for high tracheostomy, Karthik?
No, ma'am. None which I can remember.
Low tracheostomy, Saurav, Pranav, Murad Lala?
No, ma'am.
Fine. So the message is clear. Generally, it is between the second and the third tracheal drain by retraction of the isthmus superiorly. Incisions on the trachea. Do all of us take the tracheal flap, inferiorly based tracheal flap, to secure the airway should the patient need a tracheostomy, or would you get away with just a horizontal or a vertical slit or a cruciate incision also, as has been described in some cases? Do you
I think as all of us are from TMC use jaw flap, but sometimes if there is too much of calcification and there is breakage of trachea, then we just remove it and put it. You cannot take jaw flap in very rare cases.
Yeah,
otherwise,
any experience with just taking a horizontal slit in the intertracheal membrane, cartilaginous membrane? Sorry, yeah. Because
before
that
coming to TMS,
cause minimum damage, to any of the cartilage, and thus the long-term complication of stenosis is also mitigated. So, any experience with just taking a horizontal slit for any of your patients?
So I think.
Saurav, yes.
So generally, I also prefer jaw flap for all my patients.
Yes.
Murad Lala sir, would you want to make a point on minimizing the risk of?
No. I mean, if you do it, yes, I would put this thing. I would do it with the flap technique.
So only in my MS days we had done this cruciate incision in children. Otherwise we have never done.
Pediatric age group is a different ball game, and let's not discuss that. I think let's stick to just oral cancers for this.
Yes, but
otherwise,
never done.
Correct.
Oral cancer.
Because by itself, tracheostomy is a very wide topic to discuss upon. Fine. So I think we have a consensus on the fact that if you're doing a tracheostomy, might as well do it safely with a flap, so that you can, should there be a dislodgement, you can always safely reinsert the tube. So then moving on, types of tracheostomy tubes. Any preference by anybody of any particular tube? Now that all of us are in different institutes, would there be a change in the way you address a long flange or say a mobile, anything. I mean, anything apart from the regular Romson's the Portex tracheostomy tube that we use.
So in our center, we always do
double lumen.
The Portex double lumen tube. That's the thing.
So double lumen immediately at the first go, or while you change the tracheostomy tube into a double lumen?
No, in the first go itself, it's a double lumen, and when we change also.
So if I could ask, what is the advantage of adding a double lumen, particularly when the patient is undergoing, immediate post-surgery or during surgery, that if the patient has undergone a tracheostomy, why a double lumen?
So the thing is, this double lumen tube, and this cuff tube will be there for at least 5 days.
So what is
Cuff
the protocol?
double lumen tube.
Let's just jump into this. What is the protocol for change of tracheostomy tube? I think let's just combine this.
I am telling you, in first go we give double lumen cuff tube. When we are doing the tracheostomy,
the tube typically on day 5. Is that so?
Yes. Day 5 to day 6.
Day 5 to day 6. Any difference of opinion amongst the other panelists on this? Karthik, how many days does it take for the stoma to mature, or do you not follow that protocol, or you change always on day 5?
So basically now the protocol which I am following is after 24 hours I deflate the cuff. Then after 2 days I start oral liquid. So I tell them to have sips of water and I see whether they are coughing or is there any aspiration seen. If they are doing well, then I start caulking the cuff tube only. I don't change the tube. I don't change it to uncuffed tube. I just use a deflated cuff tube and immediately caulk it. Give a 24 to 48 hours caulking trial, and by the time of discharge on the 6th or 7th day, I just remove the tube and discharge the patient in a day after observation.
So I think the deflation of the cuff, I think, is to bring in the point which Murad Lala sir mentioned about difficulty in swallowing in patients who undergo tracheostomy. So one of the premises behind it is the fact that the patient's cuff is inflated. So early deflation and giving them trials with deflated tube would improve on the swallowing outcomes as well. Any opinion from your end, Dr. Murad Lala, sir?
No, I mean, I don't do it, so I won't comment on post-op care. But one point I want to make, which I think none of us have brought it up, is what is your speech rehab for these patients?
Right.
Because they got tracheostomy, they can't talk. So do you do anything for that?
That is why the fenestrated tube, sir. And I wanted to get that information from Pranav. Anything that you want to add?
No, ma'am. No, ma'am. Nothing.
For that matter, if you put in a double lumen tube at the first go, any utility of adding a fenestrated tube to enhance, or as has been mentioned, for early speech?
Look, this fenestrated tube, actually in double lumen, they have two tubes. One is fenestrated, one is non-fenestrated. Immediate post-op, you cannot put the fenestrated, then there will be leakage and you cannot put the patient ventilated if it's required. After that, you can just change, because in day 2, when second post-op day, we always deflate the cuff, and we multiple time changes between these two. But my experience is, even if with the fenestrated, patients are not very comfortable to speak at that point of time.
So the outer tube also will be fenestrated. So obviously it will not be done intraoperatively. It is during the change of the tracheostomy.
No. Outer tube is also fenestrated. But if you are giving the inner tube a non-fenestrated, then the fenestration will be blocked. So all these tubes are like that. There is a red tube normally in Portex. There is a red tube. So only the fenestration will play to act if the inner tube is also fenestrated. If the inner tube, then the outer tube fenestrated.
I agree, but that's what the outer fenestrated you will insert only when you're changing the tube. That's what I was trying to bring in. So the earlier you change, there is a chance that you can give enough anesthetic tube. And the point probably which I want to get out is the fact that we must try and start early speech as well as early swallowing rehab. So
100%.
deflation of the cuff, if you considering early speech rehab, change the tube probably in 48 to 72 hours. Try to fix enough anesthetic if that is something which is to be considered. If then I think we are running short of time. So then let's just go on to the next. This is another article which looked at emphasis on need for formalization of a multidisciplinary tracheostomy team, and I think that has come out on multiple occasions from the panelists. As far as decannulation is concerned, any protocol that is followed as far as decannulation, this is one which has been published by the Manipal group, wherein they say that they do an office-based. So this is again for all comers, not just for surgical patients. This is from an ENT department, wherein they do an office-based laryngoscopy followed by tracheoscopy through the stoma to assess whether there is a distal stenosis or no. Following which they follow the protocol of blocking the tracheostomy tube for 48 to 72 hours. If it is well tolerated, then the patient is decannulated, but with hospitalization. Now, the point I'm trying to extract from all of the panelists would be: is admission always essential for decannulation? If you discharge the patient with a double lumen tube, would you readmit the patient to consider decannulation? Again, Murad Lala sir, I don't think.
No, I don't. So I won't have experience on this.
Sure. Datta, Saurabh?
Never. It is always a outpatient. Once in a while, maybe in 1,000 patients, in 1 or 2 cases, there is a problem in decannulation. We have decannulated in outpatient. Then patient is complaining something. We have reintroduce the tube. In these cases, once or twice in my experience, we had to admit, but otherwise, all patients, they were extubated in OPD, never admitted.
Sure. Karthik, how many hours of tube blockage training would you
24 to 48.
consider before decannulation?
Yeah, so 24 to 48 hours caulking trial is a must. And if the patient doesn't have to remove the caulk even during night while sleeping also, then I am comfortable to remove the tube and decannulate him. And majority of my decannulations are done in the first admission itself, as I stated earlier. So within 7 to 8 days, and very few tube is required even after discharge. Those are decannulated as outpatients only. I do not readmit them.
Pranav, any experience with serial, using smaller tubes? I mean, serial
Downsizing.
Downsizing of
No,
the
ma'am. No, ma'am. No
Any
experience. No.
Any patient where you would recommend serial downsizing rather than complete decannulation?
Ma'am, the patient who are not tolerating the means multiple attempts of decannulation, then we can try the smaller sizes.
Sure. So in patients one of patients
Especially in the
where
total glossectomy patients, they can trouble little.
Sure. That is one of the situations. I guess that is all we have time for, but I think the points which were mentioned by each one of you were really invaluable. Any other comments that any of you want to add to in addition to what was discussed? In fact, by any closing comments, Murad Lala sir.
One more thing we've not mentioned about tracheostomy is that when you have these patients on tracheostomy, does that cause any problem for the postoperative radiation therapy in that wound healing or wound closure over there at the tracheostomy site?
Saurav made a point, sir, that one of the complications, and I completely endorse it, is non-closure of the tracheostoma, and it is occurs occasionally in patients who probably need long-term and need also concurrent starting of radiation therapy. So, any other closing comment from you, sir, Murad Lala, sir?
Nothing. As I said, I think try and
judicious use of this technique is probably your closing statement.
Hello.
Hello.
Sorry, I lost you. Pardon?
Yeah. Can I conclude your closing statement as judicious use of tracheostomy?
Sure. Yes.
Okay. Saurabh?
So again, I would like to thank Murad sir because in lot of almost in all our field of cases we were doing tracheostomy. Now we have reduced to 50%, but I'm not that means courageous to do what he is saying for total gloss or central large mandible. Again, judicious use, definitely.
Okay. Karthik?
Yes, ma'am. So, although it increases morbidity, whenever in doubt, if you feel a tracheostomy should be done, it should be done because it's a life-saving procedure in the end. And again, but judicious use.
Perfect. And Pranav?
Yes, ma'am. Again, I will say you should not be, again, you have to use the tracheostomy judiciously and you should not be, where needed, you have to do it.
Perfect. So
one more, Mitali, can I add one more thing?
Yes,
There is a saying that if you have to do an emergency tracheostomy,
Yes.
there's something wrong in your planning. You have
Perfect.
yeah.
I think it up. Judicious.
That one surgery I am scared of.
You emergency tracheostomy, you need some proper planning, preoperative planning. It should not come to that.
Yeah.
And as Karthik probably said, when in doubt, err towards the tracheostomy. And if you do not have the infrastructure or you're even slightly doubtful of your support system, do a tracheostomy. So I would like to thank all the panelists for really coming out, giving us practical tips on how to manage patients of oral cancers and how to manage tracheostomy. Thanks a lot.
Thank you.
Thank you.
Thank you.
So with this, we conclude today's day one of TMC Postgraduate Teaching Webinar 2026. Hello.
Yeah, Poonam, we are there.
Yeah. So I thank Mitali. Actually, Mitali, when I decided for this topic, only name I could think of was you, because it was a relatively, I think, difficult topic to be made, and to do a full panel discussion on this would have been really difficult. So thank you so much for bringing all the important points. And I thank Saurabh, Murad sir, Pranav, and Karthik for giving their wonderful thoughts and discussion, which I'm sure would have been very useful for all the students. So with this, I conclude today's session, and we meet you all tomorrow for the second day of our webinar on larynx, thyroid, and salivary gland at 9:30 sharp in the morning. Thank you so much. Once again, good night.